Hello, hello, hello. I hope I'm audible, visible. We'll start the session. I hope I'm audible, visible. Hello, hello, hello. I hope I'm audible, visible. Good evening. I hope you all get very great ranks, okay? Because you are really wonderfully making so much effort. 10 p.m. also, you are here watching me take a session. It's really remarkable. Me, though, I'm in a habit of working day and night. So for me, it's just one more time where I am just taking sessions. For you, I will say it is commendable because yes, it's exam time. Still, you are watching with me. Yeah, good evening. See, any exam, these chanting sessions are effective because they cover the core of any subject. Okay, anything which is very, very important. Yeah, chalo. I hope you get a good rank. And yes, if a topper come from our session, it will be really, I will give them special gift. Okay, they can just message me, and I will, yes, I will give them a very, very big gift. Anything you ask, okay. Don't ask for kidney, obviously. I cannot give kidney. Yeah, biochemistry I'll do after that. Okay. So first I will do the remaining medicine, then I'll do the biochemistry. In the end, I'll do a PSM overview, important concepts in PSM. Okay. Already have cleared up. Okay, volume बढ़ाना है. Okay. Okay. 1 second. Okay. Let me increase the volume. Let's make it 7. So I hope I'm audible now. Is it louder now? Is it better? So I think I will start the session now. Since it is louder and clear, we can start and discuss the topics. Okay, thank you very much. Is the volume fine now? Yeah, we're doing the last part of medicine, that is mainly CVS. Okay, so we have 80, yes, toppers right now with me who are watching me. Let's do. Okay, so first is, as we know that we are discussing the coronary artery disease. Heart is basically having the two main coronary artery, right and the left. Right coronary artery basically supply the inferior wall of the heart, and the inferior wall basically is made up of right ventricle. So right ventricle is inferior wall, and the leads in ECG are 2, 3 and F. So you can remember like this: if someone fail, F for fail, he will fail inferior and he will give second or third attempt. So F for fail, inferiority complex, 2 and 3 leads are there. Then we have the right coronary is done. Now the left coronary supply, basically it has two branches: the left anterior descending LADA or left anterior descending LAD, and the circumflex. Now the LAD supply the anterior wall, and the leads are V1 to V6, and also some part of left ventricle, whereas circumflex supply mainly the lateral wall. Which wall? Lateral. It supply the anterior wall, and the leads are lead 1 AVL V5 V6. So remember that. So V1 to V6 is anterior wall, then lead 1 AVL V5 V6 is your lateral wall. Don't forget the leads, they are very, very important. So once again, what is the anterior wall? It is LAD. Anterior wall is LAD. It is V1 to V6. Okay, clear? V1 to V6, in which septal are basically V1, V2, anterior is V3. So septal is V1, V2. So just write down. And septal is V1, V2 is septal leads. Okay, and lateral are V5, V6 plus also 1 and AVL. Okay, now the most common artery involved in coronary artery disease is the LADA, which is also called as a widow's artery. Okay, why? Because male are more affected than female, obviously, and if a male is going to die, the wife will become a widow. That's why called as a widow's artery. Okay, fine. Okay, now most common cause is atherosclerosis, and that is caused by poor lifestyle choices. That you already know what is poor lifestyle. Now ischemia is there. Ischemia causes the chest pain, which cause increased heart rate, sweating, palpitation. Patient feel this radiation on the left side. And classical is the clenched fist over the chest. It's called as Levine sign. So Levine sign, it is clenched fist over the chest is called as a Levine sign. Okay. Now angina pectoris is of two types. It could be classical or variant. Classical, acical exertion. So classical, acical is exertion. Variant rest. Variant rest. So if pain occur at rest, it is called as a variant or Prince metal. And remember, it is rest. Okay, Prince again rest. Rara. So remember, Prince or rest is the variant angina. So what are the mechanism? Here vasospasm is there, and because of vasospasm at rest, spasm will decrease the blood flow, and on activity there is a vasodilation which increase blood. That is auto-regulation. So that's why treatment is nitrate sublingual we can give, but we will not give CCB, MCQ. So CCB, sorry, beta blockers are contraindicated in this case. So it's contraindicated. Beta blockers are contraindicated. In case of classical, there's an atherosclerosis. As there's an increased oxygen demand due to increased heart rate, it causes, yes, ischemia, and it precipitates the pain. Pain relief at rest or giving nitrates. We can give aspirin, antiplatelet, CCBs, beta blockers. So beta blocker can be used in which condition? It can be used in the classical anginas, but not in the variant angina. Okay. Thank you, Dr. Manu. Okay. Thank you to everyone who's here. Now, stable angina is when the pain is relieved within 10 to 15 minutes, especially at rest. It is called a stable angina. Here, we will ask the patient to get the stress test done. Now, the stress test basically is a screening test. Okay. Here, we ask the patient to do exercise. In exercise, what we do? We do treadmill test. Okay. And we use the, which protocol? We use the, yes, here, Bruce protocol. Okay, that is, we do it till the heart rate is increased, the target level, that is 220 minus age. So heart rate increase. Okay, if he cannot do exercise, can't do exercise, then we will do drug stress test, and drug stress test we use dobutamine. Now both dobutamine and exercise causes what? Via the beta 1, it causes increased oxygen demand, and if there is a increase in the oxygen demand via either this, so increase heart rate, it increase the heart rate, and increased demand will precipitate the ischemia. So now if there is a ischemia, there will be ST depression more than 1 mm for more than 80 millisecond and 2 and more late. This is called as our Duke scoring. So we'll use the Duke's scoring for this particular purpose. So what is the scoring we use? Duke scoring is used. Are you clear? Duke's scoring. Okay. Yeah. Now, if there is positive treadmill test, then we go for confirmation and we'll do angiography. In angiography, we can see narrowing, the site, the number of blocks, percentage. So everything is given. And then we can go for either, yes, angioplasty, percutaneous, or we can go for the bypass. Okay. So now angioplasty, that is percutaneous intervention, is preferred in most patients. Why? It is not that invasive, so it's safer. Now here we dilate the vessel, okay, with a balloon and place the stent. Okay. Now in case it is not possible, we will go for CABG, which is coronary artery bypass. It is done rarely, and it is done for what? Indication. So CABG is done in triple vessel disease or double vessel with LAD involvement, significant LAD involvement, or I'll just skip it, or there is a left main coronary artery disease. In this case, we go for bypass grafting. And best graft is left internal mammillary artery, or we can use saphenous vein also, but best is Lima. Okay. Now drugs we give in the patients: aspirin, clopidogrel, which are antiplatelet, then low molecular weight heparin like enoxaparin. Then we can use monoclonal antibody like abiximab. So abiximab, which is glycoprotein 2B and 3A, antibody against that, or beta blocker, CCB, to decrease the heart rate, and statin if there's a severe dyslipidemia, sugar control, and also lifestyle modification, etc. So these are drug treatment in this case. Are you clear now? So that is the important concept. Okay. Okay, in the end, I'll take the remaining topic. Okay, so please don't take anxiety, Apple. I just tell you one very simple rule. Okay, if your future is in your hand, then you should not be afraid. Your future is in your hand. Okay, whatever you do, you have reached this point. You are an MBBS doctor right now. Okay, so if you reach that, next step is obviously getting a MDMS seat. You will surely get a score, that is for sure. Surely get a rank, that is for sure. what you do with that score and the subject will decide. A very capable, skilled person, let's say a Schumacher, even in Maruti will defeat a person who has a Ferrari or a race cars, a McLaren. Why? Because skills matter more than your instrument, your degree, etc. Clear? Today, I am not a teacher of medicine, but I am revising medicine for you. Why? I have confidence that I can do justice to my session. I can make you revise, even get you solve question. This is my 15th time I am teaching medicine in the past 2 years. Okay, that means what? Confidence come and then skills come. Even non-medicos are doing what? Laser treatments, they are doing scar removal and earning good money. So why will you not be able to what? Achieve success? So I'm telling you, give the exam, whatever you get, even if it's a, I'm hoping we get a very good rank, very good MDMS. Let's suppose bad habit. क्या होगा बुरे से बुरा? You're still MBBS, still get medical officer, UPSC, or you can have some diploma. I'm just giving worst case scenario. And if you do very well, you will still be able to be very, very successful. Okay, don't take stress. It's not like life and death question. It's just about getting 2 rasgulla versus 2 gulab jamun, or maybe 2 kaju katli. All are sweets, but maybe some are better, like getting a Maruti Swift versus someone getting Honda City, or maybe getting, I don't know the example, but you got the idea. Slight variation will occur 19, 20, 21. Don't worry, give your best and you are going to get a very good outcome in the future. Okay, I took this subject and I was able to happily do that subject. I am very happy in my subject. I never feel I need to change it. Why? Because I did what I wanted to do. Okay, you also do what you want to do in the life. Give the exam and I'm telling you, you'll get a very good score, very good subject, and you will do justice to that subject. Okay, be happy in what you get. Okay, that's a secret. Someone said, if you want Hindi, जरूरत तो फकीरों की भी पूरी रहती है, हसरतें बादशाहों की भी अधूरी रह जाती है. So summary is, if you have needs, you have genuine requirement, they will be satisfied even at the basic level. But if you have very big desire, very big wants, maybe I want to buy maybe some island, or maybe become prime minister, these might not be fulfilled. So that's why having a very content happy life is more important. Don't take stress. Okay, yeah. So now, what is unstable angina, also called as acute coronary syndrome? It is pain which is more than 15 minutes, not relief on rest, and worsening. That is called as crescendo pattern. Crescendo pattern. That is worsening, and it is now an emergency. It could be MI or unstable angina. So now it is what? Acute coronary syndrome. Okay, so what is pain more than 15 minutes? It's an emergency called as acute coronary syndrome. Okay, now what is happening in MI? There is a coagulative necrosis of the heart, and this necrosis releases potassium and biomarker, which causes ECG changes and also biomarker. So that is why what you do in the case of this, we'll go for MONA, which I'll discuss very soon, ECG and the biomarker. So that's why MONA, ECG and biomarker. Remember, the order is, we'll give the MONA, we'll start the MONA, do the ECG side by side, and also do the biomarker, ECG biomarker. Now, what are the cause of ECG? Potassium, MCQ. It is the potassium which is causing the ECG changes. They are due to potassium, and I'll show, don't worry. First is the earliest change is the tall T wave. Okay, so T wave become elevated, then there's a ST elevation, which is within 3 to 4 hours. Okay, so the earliest change, it is tall T wave. That is called as Pardy sign. Remember, ऊपर पर. So कहाँ चला गया? परदेसी ऊपर. So it is going up. And remember, TT, tall T and ST become tombstone. Tall T and ST become the tombstone sign. So it become the tombstone. The name itself give a hint. See, so name itself give a hint. TT, tombstone sign. Okay, then there's a T wave inversion. Last change is pathological Q wave, which appear the last and persist all life. Others are reversible. ST and T return to normal. ST and T normal after few weeks. That's why they are marker of acute ST elevated MI. Are you clear now? So that's why if there is a only pathological Q wave, it is a sign of history of old MI. So that's the case. Let me show you side by side this also. So let's start from the beginning. Okay. So what we were discussing, this is the coronary artery, which we have discussed already. Anterior wall, you can take a photo if you want. Okay, so that is LADs V1 to V6. V1 to V6 is septal is V1 V2, anterior V3 V4, lateral V5 V6. Now have a look. This is your normal ECG. This is stall T wave and ST elevation within few hours. Then there is what? There is pathological Q wave. Then there is a T wave inversion, pathological Q wave with T inversion. Here only pathological Q. So it's an old MI. It's not an acute. It's an old MI in this case. Are you clear? Old MI. Done. Now remember, what are the leads? I told you leads. Remember, if it is what leads? If it is inferior, then you will see opposite change in the, yes. So remember, reciprocal leads. Okay. So remember, inferior wall MI, opposite changes in lateral leads. That is, if there is lead 2, 3, AVF showing ST elevation, where will you see ST depression? In AVL and 1, you will get ST depression. I will show you. So that show a ST. That's called as reciprocal changes and vice versa. So remember always, there are opposite changes in the lateral lead which are AVL and 1. Let me show you. So have a look. This is an example of ST depression in lead 1 and AVL, that is lateral leads, and elevation in lead 2, lead 3 and AVF. So the inferior wall MI. So this is an inferior wall MI which is causing ST elevation in 2, 3 and F, and depression in AVL and 1. Same, this is, you can see V1 to V6 elevation is there. If there is an elevation in V1 to V6, it's a anterior wall MI. It is from V1 to V6. Anterior wall MI is there. Are you clear? Next question. This is a inferior wall MI. How you know? Lead 1 is showing depression. Can you see? Lead 2 and 3. Lead 2 and 3 is showing elevation. L is again showing depression. So that's why if you see depression in 1 and L and elevation in 2 and 3 and also F, it is our inferior wall MI. Are you clear now? Lateral will be AVL and 1. AVL and 1 is lateral. V1 to V6 is anterior wall, which is your most likely which artery? Yes, it is your LAD. LAD. Okay, fine. Now let's see biomarker. The first biomarker to increase is HFABP. That is heart fatty acid binding. If you want, I can write down. It is heart fatty acid binding protein. So it is your first to increase. But problem is we don't have a availability of kit to measure it in most places. Plus it is not as specific as troponin. So that's why troponin I is the best. It is having more specific and best for diagnosis. Okay, myoglobin 1, 2, 3 are, but these are not preferred. What is preferred? More specific and sensitive are our troponin T and I, which are the best. So troponin T and I. Now later we can also use CKMB, okay, and the time is 3 to 8 hours, okay. And remember, troponin T is longer lasting, okay, and they're also used for reinfarction, best for reinfarctions. So best for MI and reinfarction. Earlier it was said CKMB, but now it is troponin I is preferred. Now LDH flip occur. Normally there is LDH1 more than LDH2. No, it's 2 more than 1. But in MI the flip occur. Now 1 is more than 2. So normal condition, normal heart, LDH2 more than LDH. Are you clear? So 2 is more than 1. Okay. Now if biomarkers are present, okay, it's a MI, we will check ST changes. We check ECG for ST elevation. ST elevation. ST elevation, okay, ST changes, and if ECG is normal and biomarker is negative, then it's an unstable. So let's revise. If ECG is positive, it's 100% MI. Biomarker present, then also it's MI. But if there is no biomarker, no ECG, still there is pain more than 15 minutes. It's called as unstable angina. Okay. Now, what are the management? Please understand, very important. Okay. If there is ST normal, no changes, it is non-STMI, non-STMI, and here do not do thrombolysis. So remember, mnemonic, non-STMI, no thrombolysis, no streptokinase. Okay, clear? So in unstable angina and in case of an STMI, never ever do what condition? Never ever do thrombolysis. Okay, here only use the what? Mona. Which Mona? Morphine for pain, oxygen, nitrate, which is IV nitroprusside, and we give aspirin, which is chewable, around 325 to 600 milligram. Okay, we can also add antiplatelet drugs like clopidogrel, enoxaparin, beta blocker, CCB, and if patient is not relieved, we can do a delayed PCI, that is angioplasty. Okay. Now, if the patient is having what? ST elevated MI. Which MI? ST elevated MI. Then what you do is, we will do streptokinase thrombolysis. What do you do? Streptokinase thrombolysis. Okay. But remember, what is preferred? Preferred is MONA plus PCI. So treatment of choice is PCI, early PCI. How early? You should do door to balloon. That is, the balloon should be inserted within 90 minutes of the patient leaving and up to 120 minutes, that is 2 hours. Now, if not possible due to lack of facility or distance, then we will do streptokinase thrombolysis. Am I clear now? And for thrombolysis, we can use other agent also like ritaplase or tenecteplase. So we can use the thrombolysis, streptokinase or tenecteplase, ritaplase. They can be used. They are TPI, tissue plasminogen activator, tissue plasminogen activator. But thrombolysis is done if PCI not possible. MCQ. If PCI possible, please do the PCI. Don't wait for anything else. Don't wait for anything else. Are you clear? Okay. Now, what is the door to needle time? How much time you should take to inject the streptokinase? Answer is 30 minutes up to 60. So let's revise once again. A patient is brought to you with ST changes. It's a STMI. What can be done? If you can give, better do balloon angioplasty within 90 minutes up to 120 minutes. If not possible, then we do the injection of streptokinase within what time? 30 minutes up to this. And remember one more thing, if there is a inferior wall MI, there is a bradycardia and hypotension. Why? Because there is less perfusion to the right side to left side. So that is why here we start with IV fluids and inotropic agents. Also, we can skip nitroprusside because that will decrease the BP. So avoid nitroprusside in patients of inferior wall MI. Okay. Now, hypertension we have discussed already in pharma class. I just rule out. So hypertension is BP more than 140/90. We give the treatment. Give treatment. Give drugs. But the diagnostic nowadays is 130/80 as per Indian latest guideline. It is BP more than 130/80 is equal or more. Equal or more is equal to this. Rule of half is there. Half are diagnosed, half are properly taking treatment. Half, you understand? Okay. So that's the case. Now, two type of hypertension, primary and secondary. Primary is 95% idiopathic, can be environmental or genetic factor, but there are very few sign symptom, maybe headache, sleep disturbance, irritable, or he have malar flush sometime. Malar flush is there. So these could be the findings we will see in hypertension. Secondary is due to diseases like renal arteries. Most common are renal causes. Most common are renal, like artery stenosis, glomerular diseases, nephritis, Cushing, Cone, SLE, pheochromocytoma. So many are there. So they are secondary reasons. We need to investigate the cause. Okay. Now, management. Weight loss is most effective method of correcting the BP. It can correct the BP by decrease BP by 8 to 14 mmHg. In fact, some will give up to 20 can be corrected. So it is the most effective method. It can correct BP by 8 to 14, or some books say up to 20 also. Then comes salt restriction dash, that is dietary approach to stop hypertension. Okay. See, 4.5 hours was for stroke thrombolysis. Okay, Harit, it was for stroke thrombolysis. In case of this MI, we'll go for, yes, 2 hours. Okay, and also stop alcohol, etc. Now remember, when BP is more than 140/90, then give the treatment, not 130. Age less than 60 year or diabetes or nephropathy, will go with ACE inhibitor or ARB like valsartan. And if not controlled, we can add CCB along with ACE inhibitors. Okay, negative is actually inhibitors. Okay, ACI. Okay, ACE inhibitors. So negative means actually inhibitor. Okay, or if not controlled, we can add diuretics. So ACD. So the treatment here, CCB plus diuretic. If not controlled, we can add CCB, and if ACE. If still not controlled, we can add diuretics. Now question is, if 3 drugs fail to control the BP, okay, it is called as refractory hypertension, okay, or resistant hypertension. And in this case, the drug of choice become spironolactone, which is a aldosterone antagonist. Okay, yeah, I have posted all these files in my Google Drive. You can open the Google Drive link you all are having. You will see the file of biochemistry, PSM, and the latest updated medicine also. Okay, we are going to finish medicine next 5-10 minutes. Okay, now if the BP is more than 180/120, it is called as emergency if end organ damage is there. If no end organ, it's called as urgency. Okay, now this I already discussed. Ki if preeclampsia, what is the drug we will use? So if there is a preeclampsia, we will use what drug? Yes, IV labetalol. Otherwise, we use oral labetalol. In stroke SAH, we can use nicardipine, clavidipine, which are CCB. Even we can use labetalol. Okay, SAH, nimodipine. Okay, and there's very severe headache, thunderclap. Pulmonary edema, if there's a systolic dysfunction, we use nicardipine with nitroglycerin with loop diuretic like furosemide. And if it's a diastolic dysfunction, then we'll go with asmolol, which is a beta blocker. It's a short acting beta blocker which is used here, and loop diuretics. Okay, clear? Now if there's a cardiac problem, BC, dissection of aorta. So aortic dissection of aorta, aortic dissection. Or if there is what condition? There is, really sorry for spelling mistake and order. Again, you know, these are not my actual file. My actual files are my notes, but they are very bulky. I cannot use them for chanting. If I use, they will not be finished. They are more than 350 pages. Okay. So dissection of aorta or MI, we use BC. That is beta blocker plus CCB, nicardipine and asmolol. Okay, nicardipine and asmolol. Now in renal diseases with hypertension, we use phenaldopam, which is a D1 agonist, decrease the BP by renal vasodilation here. Pheochromocytoma, we use labetalol, and phentolamine, we can add nitroprusside. These are all hypertensive, but yes, emergencies. Now heart failure. Heart failure, you can have cardiogenic shock and congestion. If left heart failure, pulmonary congestion. If right heart, systemic congestion. Finding decreased stroke volume, so decreased cardiac output, BP decrease but heart rate increase due to increased sympathy. So that's why if BP decrease, it is uncompensated. BP is normal, it is compensated, right? And if normal BP, it is compensated heart failure. It is compensated HF, heart failure HF. Are you clear? Now there are two kind of heart failure based on the pathology: systolic and diastolic. Poor pumping like MI, myocarditis, ventricular fibrillation, arrhythmia, or anything which affect like dilated cardiomyopathy. Okay, HOCM. So anything which affect HOCM will not be here. Okay, remove it. Okay, like dilated cardiomyopathy, they cause poor pumping. So that's why ejection fraction will decrease less than 40-45%. What is the hallmark? Decrease ejection fraction in this case. Okay, and as the blood accumulate in the heart, cardiomegaly occur. Also there's a S3 gallop rhythm. Okay, gallop rhythm. And here we use inotrops, mainly digoxin or digitoxin. Toxin is used in what condition? Yeah, liver disease, we will not use digitoxin, and in kidney disease, we will not use digoxin. So you can use digoxin, digitoxin. I discussed that in pharma. Okay. Good evening, Aisha. Diastolic heart failure is basically less filling, like constrictive pericarditis, cardiac tamponade, or restrictive myopathy, cardiomyopathies. They cause poor filling. Okay, so EDV will decrease, that is end diastolic volume. But what is normal? Ejection fraction is normal. That's what's also called as heart failure with preserved ejection fraction. Preserved ejection fraction. This is reduced ejection fraction. Reduced ejection fraction. Are you clear? Then if cardiac tamponade, we see what? I'll just give cardiac tamponade is an emergency. It's a emergency. What happens in cardiac tamponade? Okay. What happens in cardiac tamponade? Okay. There is basically, tell me. So there is basically a compression of the heart by the increased blood of fluid in the pericardium. So it causes JVP. X is present, Y is absent, and backstride is the finding. It's an emergency. I discussed that in surgery also. Backstride, hypertension, distension of jugular vein, and muffled heart sound. Treatment is pericardiocentesis, which could be ultrasound guided. Okay. Just watch. Okay, Rajni, if you can't study, just watch what I'm doing. That is more than sufficient. Don't try your brain to study something. Say, okay, I'll just watch the video. Maybe something will come in the exam. Don't try to force it, okay, to study. Let it watch. So that's why tamponade will be what kind of failure? It will be a diastolic failure. There will be increased JVP, low BP, and muffled heart sound. Now, as S4 sound is increased in case of diastolic, here treatment is correct the filling. How? Basically pericardiocentesis, pericardectomy, and also we give beta blocker to decrease the heart rate in this case. Okay. Now, if there is left heart failure, most common cause is left heart failure. So right heart failure, most common cause is our left heart failure. There's a pulmonary ischemia, cyanosis can occur because less blood going to the lung. Poor exchange, so hypoxia and cyanosis occur. Then there is systemic congestion. Why? Because the blood is not going to lung. So there is pedal edema, which is pitting, okay, pedal or peripheral edema. Increased JVP more than 15 centimeter H2O. Then there is ascites, okay. Shifting dullness is seen. This is shifting dullness. Also there is what this, what do you say, we can do the test for the fluid, okay, clear, that is fluid thrill. Then hepatosplenomegaly is there. Also CVC liver, nutmeg liver, and hepatojugular reflux. Increased JVP on pressing over the liver. They are all the findings of findings of our right heart failure. And fluid thrill is for ascites, shifting dullness. On X-ray you'll see cardiomegaly, congestive heart failure is there. Okay, fine. Now one more thing is, if there is a left heart failure, this pulmonary edema, which give bat wing appearance and curly B lines in the X-ray. So it will give curly B line, curly B lines. Let me show you. So these are the main ones you can see. So JVP is increased. This is fluid thrill ascites. This is our cardiomegaly. You can see the heart is increased more than 50%. So more than 50% is the ratio, cardiothoracic ratio. Then this is your your pedal edema. This is your bat wing appearance. In the case of what? Your pulmonary edema, bat wing appearance. Okay, bat wing appearance is there. Fine. Now, or the other finding, there is cardiogenic shock which cause decreased urine, oliguria, cold, pale skin, fatigue is there. Then PND, paroxysmal nocturnal dyspnea is there. Person wake up from the sleep with severe sudden breathlessness. Also night sweat is there, increased sweating. Why sweating increase? Because of increased sympathetic. So that's why you can have sweating, tachycardia. Then there is also S3 galopedem, dyspnea on exertion, then basal crepitation, crackles, inspiratory rales which are heard on auscultation, and sputum is pink frothy sputum on coughing. Okay. Now if both the side are there, it is called as congestive heart failure. What is congestive means? Both right and left side show congestion, so it is congestive heart, and obviously congestive heart failure patient will die. If you die, you will come in a photo frame, so you are now in a frame, and that's why you are in a frame. Frame के अंदर हम कब आ जाते हैं जी? Framingum. So the name of the phenomena, it is Framingums. What the name is? Framingums. So what is Framingums criteria? It is used for heart failure, congestive heart failure. Frame in हम आ गए जी, heart fail हो गया जी. So that is Framingum. Diagnostic criteria for Framingum. Major criteria are all mainly left heart failure ones, like pulmonary edema, cardiomegaly is there, PND there, rales there, S3 gallop is there, and hepatojugular reflex and neck vein distension. Minor are so many there. Minor are so many there. Now, also we can use NYHA heart failure classification for the failure. So here we check is basically LPA. What is LPA? Limitation to physical activity. Now class 1, no limitation, no signs symptoms on activity, ordinary activity. In 2, there is a slight or mild LPA, sign symptom on ordinary activity. Which activity? Ordinary activity, like climbing stair, going to office, etc. 3 is your marked or moderate LPA, sign symptom at less than ordinary activity but comfortable at rest. But they are comfortable at rest. Okay. And 4 is sign symptom at rest. There is severe LPA, that is limitation to physical, bedridden patient. He has got all the findings, so he will have most of the finding of the Framingums in this case. So most of the finding of Framingum is present. Okay, let me show you this thing. Okay, so now 4 people might be coming to take him. Like example, this is your New York Heart Association for heart failure. Class 1, no limitation. Class 2, slight limitation. Class 3, marked limitation. Class 4 is severe. 4 people will carry them. And remember the song, Astronomica, 4 people. So if 4 people are carrying you, that is your class 4. Okay, 4 people. Can't even, yes, do. So this is class 4. Can you see? Okay. Now, what is the treatment? For systolic heart failure, inotropes are the preferred agent. If there's a cardiogenic shock, that is decreased BP. So if there's a decreased BP, cardiogenic shock, then drug of choice is noradrenaline or dobutamine. Both are equally efficacious. In some place they prefer noradrenaline, some place they say dobutamine is the drug of choice. Both are using beta 1 to increase the cardiac pumping. Okay. Now, second, if there is a compensated heart, the preferred drug is ACE inhibitor. Why? They prevent remodeling of the heart, and that's why they decrease mortality and morbidity. So what are the best for decreasing mortality and morbidity? Morbidity and mortality is decreased best by which agents? ACE inhibitors. So they are the preferred drug. Then loop diuretics are mainly drug of choice for acute pulmonary edema, and beta blockers can be used in compensated chronic or diastolic heart failure, contraindicated in acute, decompensated and systolic heart failure where the BP is low. So if the BP is low, we will never ever use what? The beta blockers. Okay. Now this NYHA classification. Now I'll make a murmur easy for you. First remember the summary. So summary I am giving you is right like this: S1 to S2, S2 to S1. This is systole. This is diastole. This is A2 P2 as you all know. Now remember a simple summary. If they divide into 3 parts, this is early, this is mid, and this is late. Again, early, mid, or late. So this is summary. So early, mid, late, early, mid, late. That's diastole. Are you clear? So that is diastole. Now remember, if it is a what? Mid murmur, it is always stenosis. So if it is a mid systolic murmur, MSM or MDM, it's a MDM. So it is a MSM. It looks like a diamond shaped murmur. Diamond shape. So it is MSM, and MDM is a decrescendo murmur. It's a decrescendo rumbling murmur. So if it's MDM, it is MS, and if MSM, it is AS, could be PS. Okay, so remember ASPS, MDM is MS. Just the most important finding. If it's a mid systolic murmur, it is AS with ejection click. If it's a decrescendo, so diamond shape, it's look like a diamond shape like this. It look like a slope murmur. So if you get a diamond shaped murmur in the middle of systole, it is aortic stenosis. If you get a mid diastolic rumbling decrescendo, it is a MS. Very simple. Okay, MS. Okay, fine. Remember this. That's it. Okay, and let's start the discussion now. Okay, rest I will discuss later. And if you get a early diastolic murmur, EDM, it is AR. EDM is AR. EDM is AR. And if you get a murmur which is all the cycle, pan systolic, PSM, it is MR. How to remember? PSM पढ़ के मर गया MR. So MR is मर गया PSM, मर गया PSM. These are the most important murmur: pan systolic MR, mid systolic AS, early diastolic AR, and mid diastolic is MS. In my proper class, I've explained all the splitting, etc. Right now time is less, so I'm just doing the main things. Okay, fine. Okay, now I discuss for left side it's MSMR or ASAR, for right side it is TSTR or PSPR. Okay, now causes: if newborn or since birth is congenital, if it is old, degenerative changes, if young, they are giving young child or adult. In India, infection, still rheumatic fever is one of the topmost reason for the murmur. Then world, if they are saying world, it is autoimmune diseases worldwide because infections are less. Now valve, remember mnemonic is MAT-PO, yeah, MAT-P. Okay, so that is mitral, then aortic, then tricuspid and PV. So most affected is mitral valve, is the biggest area, 4 to 6 centimeters square. Why? Because MV is largest. Chokka, 4 to 6 centimeters square. So the largest valve, MV, that's why it is affected the most. So it's affected the most, MV is affected the most. Are you clear? Then investigation of choice here, mainly we do echo, then we can do X-ray, ECG, MRI, etc. Then treatment is, if mild asymptomatic, we just ask them avoid exertion because that can trigger, yes, sign symptoms. Then if severe heart failure, low ejection fraction, we can go for surgical treatment like valvuloplasty, valve replacement, and treat the heart failure. Always treat the heart failure. Okay, this I give you. Early is, yes, MR. So it is mid systolic murmur. Okay, so MR is what murmur? I'll just go back. So MR is PSM, pan systolic murmur. Okay, so MR is pan systolic murmur. MR, please correct it. MR is pan systolic. MSM is AS. Okay, MSM is this, and MR is PSM. It's PSM. It's by mistake. Okay, and early diastolic is AR, and mid diastolic is your this. I've discussed that already. Now remember mnemonic: आस पास मत शर्माओ, आस पास देखो मत शर्माओ. So ASPS is MSM. ASPS, आस पास देखो मत शर्माओ, MSM. Then ASPS is MSM. I discussed. In AS, less blood goes to the aorta. That's why SAD, person is sad. Remember, as mnemonic is sad. But sad, syncope, angina, dyspnea. Why syncope? Brain not getting the blood, heart not getting the blood, myocardium. So angina plus dyspnea because of lack of oxygen and blood to the body. Then if they ask you what is MS, mid diastolic. Remember, if you are having what? MS degree, someone will have MD. So what are you doing? You're giving the NEET. Why? You're giving the NEET to get either MD, MS. So in MS, MD degree is a must. So remember, so MS or MD. Okay, so after NEET PG, what will you get? Some will get MD, some will get MS. Like I got MD, some will get MS. So mid diastolic rumbling murmur with opening snap. So opening snap and mid diastolic, which murmur? Rumbling murmur, which is decreasing. Okay. Then what is the finding of MS? In MS, what happens? In MS, there is left atria enlargement. Why? Because the blood is not going to the right ventricle, so it's enlargement. There's a main hallmark, enlargement. There's a hallmark. Okay, fine, very important. Okay, must do. Okay, then MR is pansystolic murmur, PSM. Mitral valve prolapse is one of the most common causes. Okay, and its clinical feature are mainly young female with acute panic attack with pansystolic murmur, which increase on standing. So the hallmark, this PSM, it increase on standing, sort of, and murmur. Why? Because it pull the mitral valve down, so murmur increase on standing. So if they give this finding, it is a short case of pansystolic murmur, MR, mitral valve prolapse. Okay, now AR. AR is EDM, early. So early murmur, AR, early murmur is AR. It is mid diastolic murmur. Which murmur? Mid diastolic murmur, mid diastolic. Signs are collapsing or water hammer pulse. What the sign is? Water hammer or collapsing pulse. The pulse will rapidly decline. Corrigan, that's dancing carotids. Okay. Quincase, which is fingertip capillary pulsation, it can be visible. Hill sign is BP difference in upper and the lower limb. Then Traube is the pistol shot over femoral artery. Plus there is what? Muller sign. I just write the someone. There is pulsation of the uvula. That is Muller sign. Also there is what? Rosio sign. So many signs are there. Okay, there's a long list of sign. The lighthouse sign. So many are there. That is flushing of the forehead. There's lighthouse sound. Lighthouse sign. So I will not go. So summary: MS give MDM, AS give MSM, MR is PSM, and AR is EDM. It is EDM. Okay, done. So with this we'll finish up our what? The main concepts in this. I will just show you some extra point that you should remember and you should understand. Better I'll write it here because that will, yes, help us. Okay, so what I'm doing is I'm writing important ECGs that you should understand, right? Okay, important ECG. Okay, so if you get a straight line, it is called as asystole. Asystole, and treatment is CPR with adrenaline, MCQ. So this, okay. If you get what? If you get a, yes, very high rate irregular, no wave, it is a VFib. Treatment is DFib, then CPR. Okay, DFib with CPR. Okay, clear? DFib with CPR. Okay, then if there is a tachycardia, if there's a increased heart rate more than 100 per minute, okay, more than 100, and P wave absent, okay, check. If narrow QRS, this is PSVT or SVT, you can say. If wide QRS more than 100, it is your VT. So remember, it's a VT. I'll just make it, this is VT and this is PSVT. So in PSVT, you get a very narrow QRS complex. So that's the main thing. Wide, VT is wide QRS. If narrow, it is PSVT. Okay. Now remember VT and PSVT. Remember treatment. In VT, drug of choice is amiodarone. Amiodarone is the drug of choice. Amiodarone or lignocaine as per some books. Now, if not improve, we will use cardioversion with synchronized DC shock. It's with the beat. Okay. And PSVT, drug of choice is adenosine. So adenosine. Okay, I'll show the photos also. Adenosine And for prophylaxis, we will show or give what? Yes, we will give what? For prophylaxis, verapamil. Okay. But remember, if BP is low, that is patient is hemodynamically unstable, always remember we will go for cardio version. Whether it is VT or SVT, we will give what? We will give not the drugs, because drugs will not act. He's in, yes, not able to pump the blood. How will the drug act? So we will always go for cardio version. So the treatment of choice of unstable, hemodynamically unstable patient is always cardio version. Are you clear now? So that's why cardio version. Now remember atrial flutter or fibrillation also. If you see sawtooth, 4:1 ratio like this. This is sawtooth. Sawtooth is atrial fibrillation, atrial flutter, sorry. And if you get irregular pulse, no P wave, and variable RR, like this. This is your classical case of what? So if you get variable values, then it is your case of what? Our atrial fibrillation. Are you clear? So this is atrial. I'll show the photos also. It is atrial fibrillation. So it is our atrial fibrillation in this case. Am I clear now? So I will just show the photos. Please remember they are very, very important. And what the management? First, if same hemodynamically unstable, even in AFib or flutter, we will go for what? Cardio version. Are you clear? Again, go for cardio version. If stable, if BP is normal, that is if stable hemodynamically, the drug of choice would be for rhythm control, E-butylate or amiodarone. E-butylate, which is class 3. Okay, class number 3. So E-butylate is class number 3. So E-butylate is class number 3. Or for rate control, we can use ABCD. A is for, yes, again amiodarone, B beta blocker, C CCB, D is digoxin. Okay, D is digoxin. Okay, so rate control. Okay, so if there's a rate control, we can use ABCD. For rhythm control, we can use E-butylate. Okay, and if hemodynamically unstable, we'll go for this. Okay, that's what I'm telling you, the management of fibrillation and flutter, atrial fibrillation and. Are you clear? Next, last, if you get polymorphic VT with changing QRS amplitude, it is TDP, it is Torsades, like this. Again, they are wide. So if there is a, yes, change in the amplitude, it is also called as a roller coaster or stream roller. This is your Torsades. This is your Torsades. So in Torsades, what is the drug of choice? Magnesium sulfate. It is Torsades. So it is drug of choices. What is the drug of choice? Yes, we will give what? We will give what drug? We will give here our magnesium sulfate, MgSO4. So I hope now it covered all the important topic. So I'll save it. So this is the summary of the ECGs also. If Wolff-Parkinson-White syndrome, we will do the ablation of the bundle of Kent, and we can give what drug? We can give propafenone or E-butyl. Okay, let me show you the ECGs and then we'll be finishing the case. Also, I'll do the remember hyperkalemia findings are similar to MI. So one mnemonic, hyperkalemia is similar to MI. Hyperkalemia is similar. Tall T wave, increased PR, later arrhythmia occur. Later arrhythmia occurs, sine wave pattern, and you can see yes. Okay, hypokalemia, ST depression, inverted short T wave, and also our PR will increase. Okay, and what I'm doing is your most expected topic only. Okay, and in severe hyperkalemia more than 8, you can see sine wave pattern. That is sine wave pattern. Okay, so do this. This is more than sufficient. Okay, and if you see what do you say, William Marrow, remember that is your slurred or notching of QRS. It is your what changes? It is your bundle branch block, right and left. Okay, now this is mild tall T wave and prolonged PR. Then there is a loss of PR. Finally, this and treatment of hyperkalemia. Other treatment is we will give calcium gluconate, insulin, and salbutamol inhaler. Salbutamol. Okay, so these are the drug of choice. Okay, yeah, okay. So I will do acid base also. I'll make it easy. Okay, point is time is less. Okay, Harith, that is a problem. You know, if I have time, I can do, but okay, if you are saying, I will do that. And also the other ECGs, Arrhythmia ECG. Can you see here? Here P wave is absent and the RR is irregular. Sometimes it is 3 box, 2.5 box, 3.5. So that's why it is called what? It's a AFib. It's a AFib. It's a AFib. Okay, so it is AFib. Okay. Then this is sawtooth, classical sawtooth atrial fibrillation. This is our SVT. You can see narrow QRS and tachycardia. So it is our SVT or PSVT. Then this is our VT. You can see the monomorphic VT. Same. This is called as concordance. The positive R wave in V1 to V6 is called as concordance. Then this is your fibrillation. You can see very high heart rate and there is no wave identifiable, very high rate. This is called as VF. That is ventricular fibrillation. This is your capture of fusion beat, which is seen in again VT. Sometimes normal QRS can be there. That is capturing the tachycardia. And this is Torsades. Look like a stream roller. Are you clear? Now, for acid base, I will just tell you a basic summary. Remember, for acid base, if there is, I'll just tell you acidosis. Remember, if there's a decreased pH less than 7.34, it is acidosis. Now, if there is decrease by carbonate, how much? Less than 24. Some books say 22 also, 22 or 24. Okay, yeah, I will share it, don't worry. Okay, this is metabolic, and if there is a increased PaCO2 more than 45 mmHg, it is respiratory acidosis. And if both occur, that is low bicarb less than 24, 22 and high CO2 more than 45, it is, if both occur, it is mixed acidosis. Okay, now in metabolic there is a respiratory compensation. If there is a respiratory compensation, okay, what will you see? You check PaCO2. If PaCO2 is low, it is compensated. Is low, it is compensated. if normal PaCO2 uncompensated. So remember, if low PaCO2, that is less than 35 mmHg, it is what condition? It is our compensated. Are you clear? If PaCO2 is normal, that is 35 to 45, it is uncompensated. If more, it is mixed acidosis. Are you clear? And remember, if low bicarb, low PaCO2 but normal pH, then it is fully compensated. Most likely it's a metabolic acidosis. So these are the basic rules you remember for your exams. Okay, now if there's a respiratory acidosis, what are the important? Here we check the bicarbonate for compensation, metabolic compensation. So there is a metabolic compensation. Same rule. What rule? If there is increased bicarbonate, it is compensated. If normal bicarb, it is uncompensated. Clear? So it is uncompensated. So this is your respiratory acidosis. Are you clear? Now in metabolic acidosis, in respiratory treatment is what? Yes, it is correct ventilation. Correct the ventilation. And in metabolic, I'll discuss. In metabolic, again, first is treat the cause. First is always treat the cause. So in metabolic, we will always treat our cause. So we'll make the cause treat, then add bicarbonate. Add bicarb. Okay. How much? As per base deficit. And last would be, last treatment, if still not, last would be dialysis. So for refractory acidosis, we will do dialysis. Okay. So am I clear now? So the option first, treat the cause. Like if diabetic ketoacidosis, we'll try to correct the ketoacidosis, not acidosis first. Then you can add bicarb as per base deficit. Now I'm telling the formula. How do you calculate base deficit, BD? So base deficit is given as 24 minus bicarb. Example. Okay. And what are the bicarb given? So bicarb given is half body weight. Actually the formula is different. I'm giving the easy formula. It solves most of the question. Half body weight into base deficit. So that is an easy formula. Complex formula I don't want to do now. Okay. So half the body weight into base. Like example, let's say someone bicarb is 14. So it's obviously metabolic acidosis. Why? Low bicarb is metabolic, high CO2 is respiratory. If it is less than 24, it's metabolic. Now what do you do? What is the BD? So BD will be 24 minus 14, that is 10. So 10 is the deficit. Now what is the body weight? Let's say body weight is 60 kg. So into 60 by 2, that give you 300 milli equivalent. So how much bicarb is needed? 300 milli equivalent is the bicarb that we will require in this patient. So what is the amount needed? 300 milli equivalent is the amount. 300. Okay. Done. Now comes the question. Metabolic acidosis, we will always check anion gap. What you check? AG. Anion gap. And normal is 10 to 14. Given by sodium minus chloride plus bicarb. Now remember, there are two kinds of acidosis. One is NAGMA, other is HAGMA. NAGMA and HAGMA. What is NAGMA? It is normal anion gap. It is high anion. I'll make it easy for you. Never you will forget. So remember, NAGMA is basically GIT or kidney bicarb loss. GIT or kidney bicarb loss. Are you clear? So whenever there is a loss of the bicarb in the kidney or GIT, that is your NAGMA. Why? Because GIT or kidney bicarb loss is always compensated by chloride. So what happens? Loss and chloride gain is there. So that's why it compensates. Here only bicarb loss, no chloride gain. So that is why there is increase the anion gap. So easy. So which condition there's a chloride gain? It is NAGMA. So NAGMA is very simple. Four main condition: RTA, renal tubular acidosis. If ever question come for RTA, I'm telling a very simple rule. In RTA, I'll tell you later. Okay, let me finish. RTA, then acetazolamide, which is CA inhibitor, CAI, carbonic anhydrase inhibitor. Then Addison disease, which is lack of, I discussed that Addison disease is decreased aldosterone, and aldosterone cause what? Acid secretion. So without aldosterone, there will be less acid secretion by the kidney. And D is diarrhea. Diarrhea is any GIT bicarb loss. If there is a gastric vomiting, it will cause alkalosis, but diarrhea will cause acidosis. So what are they? And rest all. So remember what are the mnemonic we are making? RTA, acetazolamide, Addison, diarrhea. So it make a very famous mnemonic RAAD. So remember the mnemonic NAGMA. What is the anion gap? 14, 14. NAGMA 14 RAD. RAAD. So remember NAGMA RAD. तो क्या है NAGMA? NAGMA is RAD. RAD. What is the anion gap? 14. 14 is. So NAGMA RAD 14. Remember the mnemonic? NAGMA RAD 14. NAGMA RAD 14. And what is HAGMA? Rest all. We are right. Non-RAD. Very simple. Non-RAD is HAGMA. One more hint. They are foreign or organic acids. राडा बना लो भाई, राडा बना लो, राड बना लो, तुम्हारी मर्जी, इट्स अप टू यू. आई रिमेंबर लाइक राड. Okay, नगमा राड. Now foreign organic acid. So remember, if there is a foreign acid, organic acid which is not kidney GIT related, 100% it's a HAGMA. So no need to remember mud pile, fud pile. I don't even remember mud pile myself. I remember is foreign. Like example, if someone say what ethanol, methanol, etheric acid, salicylic acid, picric, oxalic, all will cause a HAGMA. Example, diabetic keto, it's a organic acids. Remember, butyric acid, hydroxybutyric acid, acetic acid, or there is starvation which cause lactic acidosis. Then ethanol, methanol, glycol, all glycol. Glycol is antifreeze. Then starvation which cause again lactic acidosis, starvation. Then our INH, paraldehyde. So all organic acids. Okay, all organic acids. Okay, done. Then what else is there? Tell me what else. Yeah, there could be salicylic acid, aspirin, uremia, I'm putting etc. So all these cause what? They all cause which condition? They cause what condition? Our what condition? Yeah, they all cause high anion gap. So they cause what? High anion gap. So is it clear now? So they cause high anion gap. Okay, fine. So remember, low anion gap is a very rare condition. It is mainly seen in high level of positive ion. If you want, I don't want to remember, low anion gap is basically seen due to increase in cations. It is due to increase in cations. Example, increase calcium, magnesium, potassium. So I hope it's clear. So any cations will cause, even lithium. So any cations can cause what? Increase in the anion gap, sorry, decrease in the anion gap. Are you clear? So they are low anion gap. That is hypercalcemia, hyperkalemia, magnesemia, lithium. So cations, when they are increased, they will cause a, yes, low anion gap. So these anions will cause. Okay, So am I clear? So I think with this, let me finish the medicine, then I will proceed to this. Okay. And nephrotic, I already told you, if there is only proteinuria, it is nephrotic. If hematuria also, it is nephritic syndrome. Okay. And in hematuria, yes, Coca-Cola urine is there. Treatment is same for both. We will give a steroid first. If not controlled, immunomodulator like azathioprine, cyclophosphamide is given. In case of nephritic syndrome, we can give, but also we can give our what drugs, what agents? We can give ACE inhibitor also. Okay, ACE RTA. So in RTA, just remember a very simple rule. In RTA, we told you it's a normal, yes, a NAGMA. It's a NAGMA. Now there are two types, 1 and 2. 3 is mixed, 4 is what? It is excessive aldosterone, sorry, Addison disease. Now remember, 1 is distal tubule damage. It is distal tubule. This is proximal. And remember here, look at the urine pH. It will be more than 5.5. And proximal is less than 5.5. So if it is less than 5.5, it is proximal. If more than 5.5, it is our distal. Are you clear? And there's also bicarbonate urea, severe bicarbonate urea. Because not absorbed. Here, there is rather renal stones are there. Because of high pH, citrate will cause precipitation of calcium as stones. So I think that is more than sufficient. Okay, Harit bhai, this is for RTA. Treatment of both is same. We give bicarbonate, potassium because low potassium. Okay, and we can add the, yes, hydrocortisone mainly in this. Okay, mainly into. So this is the RTA treatment. Okay. So let me move to other system. Otherwise, we'll never be able to finish anything. I'm really sorry for stopping medicine here. I want to do other concept also, but my problem, time is the issue. Okay. So let's continue with other. So now I will do first, let's do the biochemistry very fast. And then I'll do the PSM important rapid. Okay. So let's discuss carbohydrate metabolism. First, remember the enzyme and rate limiting. So glycolysis is also called Embeden-Meyerhof pathway EMP. The site is cytosol, we all know, and the rate limiting is PFK, phosphofructokinase 1. For Krebs cycle, which is also called as the tricyclic TCA or citric acid cycle, is mitochondrial matrix, and the enzyme is isocitrate dehydrogenase. Gluconeogenesis, liver and kidney, it occurs cytosol mitochondria. Enzyme is fructose 1,6-bis phosphatase. Okay, 1,6-bis phosphatase. Glycogenesis is again done in liver and the skeletal muscle, and they save the glycogen for future use, and this by glycogen synthetase. Okay, and glycogenolysis is by phosphorylase. And remember, it is very important that it is breaking the glycogen back to glucose. Then HM shunt or pentose phosphate pathway is liver skeletal muscle cytosol. It is basically, yes, G6PD, that is, yes, glucose 6-phosphate dehydrogenase. It's very important. Why? Deficiency cause decreased glutathione, which cause hemolysis. So it's deficiency cause hemolysis. So they will give a history of malaria, anti-malarial drug, and that will cause the, yes, this. So let's revise once again. So glycolysis, what is the pathway? It is phosphofructokinase. CREB, isocitrate. Remember CC, citrate citric acid. So remember citrate citric acid. Glucogenesis obviously is 1,6-bis phosphatase, and genesis is synthase, lysis is phosphorylase. Are you clear now? And HM shunt is again very famous. G6PD enzyme is for HMP shunt, which is helping glutathione synthesis. Glutathione. Now, protein metabolism, urea cycle or the ornithine cycle is liver of then cytosol and the mitochondria. Enzyme is CAT. Okay. Then CPS1, then carbamyl synthase. So there are 3: CAT, then CPS1 and carbamoyl synthase. Lipid oxidation beta mitochondria, and it is again CAT1 carnitine acyl transfer MCQ. So it is carnitine acyl transfer CAT1, here also CAT1. Then ketogenesis is mitochondria HMG CoA synthase. Remember, and HMG CoA reductase is for cholesterol MCQ. So synthase is for ketogenesis and reductase is for cholesterol MCQ. Fatty acid synthesis occur in cytosol. Okay, so remember, synthesis and cholesterol both are in cytosol, but oxidation is in mitochondria. Enzyme is acetyl coenzyme A carboxylase. It is carboxylase. Now cytosol HMG CoA reductase is the enzyme in this case. Okay, so let's revise. That's why it is blocked by what drug? Yes, very famous drug. Which drugs? Yes. So inhibited by statins. Okay, for treatment of hypercholesterolemia. Okay, now obviously for nucleotide metabolism, purine synthesis, the enzyme is PRPP glutamyl amidotransferase. Okay, so that is used for what? For our purine synthesis. Okay, now very important, the mnemonic, as we all know, is Vaughan pumped Corey and made her tired. So mnemonic: Vaughan pumped Corey and made her tired. So remember the mnemonic: Vaughan pumped Corey means pumped up. So Corey बोला, Corey उठ जा, Corey चल, घोड़ी पे चल, and उसको पंप किया और उसको इतना काम कराया, इतना बेचारी थक गई. So Vaughan pumped Corey and made her tired. Tired is yes. Okay, so are you clear? So Vaughan pumped Corey. Okay, so are you clear now? So that is the case. Are you clear? So clear now? Next question, right? So what is the Vaughan? Vaughan is Vaughan-Garrick's disease, in which you can't break the glycogen, so glycogen accumulate. That's why it's a glycogen storage disease. So the glycogen enzyme is glucose 6-phosphatase. Remember, this enzyme is absent in muscle and only liver. So that's why what muscle cannot do, it cannot give glucose to the blood. Who can give? Yes, liver can give. So that's why this deficit, it causes accumulation of the glycogen called as Vaughan-Garrick disease. MCQ, Vaughan-Garrick. Abhi biochemistry to kara raha hu. So Vaughan-Garrick disease. Then pompase. So it is pompase, in which again there is mutation in the GAA gene, that is alpha glucosidase. So glucosidase A alpha, and enzyme is acid maltase. What is the enzyme? Acid maltase. Remember, acid maltase. Okay, now remember BD, इसका mnemonic क्या है? BD. So remember, इसका mnemonic है A और B का branching and D branching. So Corey is what? D branching, Anderson is branching. So remember, it is what? C का D और A. So इसका D branching and इसका branching. So are you clear? So Corey is D branching, enzyme deficiency, and Anderson is, remember what the mnemonic we make? It is A, B, C, D. So in A is branching, C is D. So Anderson is branching, Corey is D branching. Are you clear? So I hope biochemistry is also now looking sensible and easy to understand. Okay, so Vaughan-Garrick, what is the enzyme? Phosphatase. Pump is what? Remember, in pump, proton pump. When do you give proton pump? PPI for acidosis. So remember, acid. So PPI, proton pump inhibitor. When do we use proton pump inhibitor? For acidity. So acid maltase. It is acid maltase. Then Corey is debranching and Anderson is branching. Made McArdles. Made is McArdle. So let's again, Corey is basically yes, debranching. Anderson is branching enzyme. Then come McArdle. McArdle is muscle glycogen phosphorylase, which is the rate limiting enzyme for glycogenolysis. Okay, Her's disease is hepatic glycogen phosphorus. So remember last two, McArdle, Mac and Hurdle. And remember hepatic phosphorylase, McArdle, ma muscle. So remember May and Her both are your yes glycogen storage disease in which phosphorylase is affected, and they are 1 to 6. So remember, so what are the 6 disease? Von pumped Cori and made her Taristolis. Okay, so this is the last disease, that is number 7. 1 2 3 4. And what is made and hers in both? What is the deficiency? It is phosphorylase. Phosphorylase. So it is phosphorylase. Only made is muscle phosphorylase, and this is hepatic phosphorylase. So what is made is? Made is McArdle, her is her disease. Her is her disease. So I think now you'll remember it forever. Okay, clear? So we are fulfilling all our promises. We said we will revise even biochemistry, psychiatry, pediatrics, anesthesia, physiology, patho, pharma, medicine, I don't know, whatever, derma. Okay, so I think all important subject. OBG not covered, really sorry. OBG Ramya ma'am did whatever she did is sufficient. Okay, please don't ask me to teach OBG, then I have to study OBG. And I tell you, okay, I have zero command on OBG. If I will teach you OBG, you will say better I would have studied myself. Okay, why? You know my skills are not good. Okay, but I will try to do some topic in OBG. I will try in the end. Okay, now let's start. Now, essential fructoseuria is obviously fructose in urine, very commonly seen in the newborn baby. Enzyme is fructokinase. Enzyme is fructokinase. And fructose intolerance is when you can't break the fructose, here aldose B. Remember, intolerance is aldose B, and our essential fructoseuria is fructokinase. Fructokinase. Now, what is galactosemia? Here the person is having what? The increased level of this galactose, or the enzyme galactose 1 phosphatase uridyl transferase. So that is galactosemia. So remember, all these are exam question, 100% exam. Now proteins, phenyl ketone, and remember all these, all ureas, they are autosomal recessive. This I discuss in patho, are autosomal. So remember phenyl. So remember, when you have phenyl, you kill the mouse. So remember, enzyme is phenylalanine hydroxylase. Phenylalanine hydroxylase. Okay. Alkapton urea. Remember alka. Alka ke kale bal. Alka. If you reverse the word alka, it sounds like kala. Alka, kala. Kala means black. So urine become black. So how to remember the mnemonic? Urine becomes, so alka ka kala. So alka kala. Okay. Homogenetisate oxidase. What are the enzyme? Homogenetisate oxidase. Okay. Maple syrup disease. So burnt sugar odor, very sweetish in the smell. Branch chain. So burn is branch. Burn, and it is sugar. Maple is sugar. Meetha. So maple is apple. Apple is sweet. So sugar is this. Okay. So sugar is there. So remember, syrup is sugar. And it is basically branch chain keto acid dehydrogenase decarboxylase, or D. So question for you, branching and debranching, what disease occur? Question for you, branching and debranching, what will occur? Question for you, branching and debranching, what are the disease because of branching deficiency and debranching? Mnemonic ABCD. ABCD is the mnemonic. ABCD. Tell me. ABCD. Tell me. No one giving the answer. I think everyone is busy somewhere. Okay. No one gave the answer. So remember, Anderson is branching, Cori is debranching. Remember I told you A, B, C, D. So Cori is debranching, Anderson is branching. A, B, C, D. Yes, Cori is debranching, A, B, C, D. Na? and muscle and her made her is phosphorylates. Muscle and hepatic phosphorylase. Tired is twice. Okay. Okay, let's come back again. Then lipid storage disease, Niemann-Pick's. So here what happens, the lipid and cholesterol accumulate and it causes the steatosis, and you can see the fats. This fat appear clear in the histology. So that is Niemann-Pick's. Okay. Enzyme is sphingomyelinase. MCQ, sphingomyelinase. Then come Gaucher's. So Gaucher's is GGG. Gaucher Gaumata glucocerebrosidase. So remember, glucocerebrosidase is your Gaucher's. Okay. So in, and again it is and it is what, again what disease, autosomal recessive. Then it is, you can see the, yes, globoid cells in this case. Krabbe is what, demyelination. Enzyme is what, galactocerebrosidase. There is demyelination which cause neuropathy. Okay, neuropathy. So galactocerebrosidase. Okay. Then Fabry's is basically, what are the enzyme in Fabry's? It is alpha galactocerebrosidase. So don't get confused. If it is beta, it is causing Krabbe. So beta is Krabbe, but if it is Fabry, it is the galacto alpha. So alpha is Fabry. So if it is Fabry, and if it is Krabbe is galacto. Beta galactocerebrosidase. If it is Fabry, it is alpha galactocerebrosidase. Okay, very good. Now obviously there is inclusion body, okay, with myelin like appearance, that's there. Now Tay-Sachs disease, there is what, destruction of the neurons in the brain. Hexoaminidase. So there is a hexoaminidase A, and if it is A and B, sand off. So how to remember sand off? And so what is A only? Tay-Sachs. So if Tay-Sachs is only A, if sand and is both A and B, and is both A and B. Now we see nucleotide defects. First we have the Lesch-Nan syndrome. Nail and the lip biting, and enzyme is HGPRT. Okay. Now let's see the formation, amino acid and the product. Tyrosine is used to make what? T3, T4, catecholamine, melanin. So they are all made from tyrosine. So what is tyrosine used for? Catecholamine, epinephrine, norepinephrine, dopamine, all are made from tyrosine. Okay, and the enzyme are what? Yes, hydro. First there is, yes, hydro. Which one hydro? Tyrosine hydroxylase, then carboxylase, then again beta hydroxylase. So what are the mnemonic? 3. Then tryptophan is, again, it is vitamin B3, serotonin and melatonin. In fact, what is serotonin? It's 5-hydroxytryptamine. Okay. Then histidine is for histamine. Arginine is creating the nitric oxide. Now inhibitors, fluoride inhibit enolase. That's why fluoride is added in stored blood. So that's why used in blood bank. It inhibit the enolase. Then barbiturates and rotenone inhibit complex 1 electron transport chain. This is a 100% exam question. Remember 1. So barbiturate एक नंबर का क्या रेट है? रेट 1 रेट. So barbiturate, बारबी का रेट क्या है? 1 रेट. Barbi 1 rate is complex 1. Malonate is 2. So malonate is 2. And all this carbon monoxide, cyanide, H2S is complex 4. All of these CC are complex 4. So 4 is CO, CN and H2S. Okay. Oligomycin is 5. Mycin is 5. Okay. Mycin is, so oligo has 5. So oligo is 5. Okay. And malonate is 2. Okay. So let's revise. Fluoride inhibit enolase. Barbiturate and rotenone inhibit electron transport chain complex 1. Malonate is complex 2. COCN H2S is complex number 4. And oligomycin complex 5. Now what is the classification of amino acid? Aliphatic are mnemonic G vali. There is glycine, valine, alanine, leucine, isoleucine. They are all aliphatic. Then hydroxyl group are serine and threonine. That is ST. They are hydroxyl group. Sulfur containing are basically cysteine, cysteine and methionine. Cysteine, cysteine, methionine, MC. So sulfur is cysteine, cis sulfur, and methionine and acidic are AAGG. Aspartic acid, name itself has acid. Glutamic acid, name itself have acids. Remember, others are ending in ines. So all are ending in ine, but acidic ones are ending in ix, like aspartic acid, glutamine, glutamic acid. So it's glutamic, so it become glutamic, and asparagine. So remember, what are acidic? Aspartic, glutamic, and glutamic is glutamine, and asparagine. So these are acidic. Basic are hull. Hull is HAL. So histidine, arginine, lysine. So these are your basic. So remember, basic is his, arginine and lysine. Okay, his, arginine and lysine. Aromatic is PTT. They are all TT ones. So TT ones are what? TT. TT are aromatic. Aromatic is TT. Tyrosine, tryptophan. Tyrosine and tryptophan are what? Aromatic. Also phenylalanine. Okay. Essential. Nowadays they have added two more. So what is essential? The mnemonic is TV till 8 p.m. Now we have semi-essential also, so it become total one. So TV till 8 p.m. So TV, tryptophan, V is valine. Till thyrronine, isoleucine, leucine, lysine, all else. 8 p.m. is our phenylalanine and methionine. They are the 8 semi-essential are HA, histidine and arginine. So what is the essential one? TV till 8 p.m. T for tryptophan, V for valine, then T is thyrronine, then isoleucine, leucine, then lysine, phenylalanine and methionine. They are essential. Semi-essential are HA, histidine and arginine. Ketogenic are L1. Remember T were what? T were our aromatic. Hull is our basic. Acidic are A's. They are acids. Aspartic, glutamic, okay, glutamine. Then ketogenic are L1s. Glucogenic and ketogenic. Pit, Brad Pitt. So pit. They are phenylalanine, isoleucine, tryptophan and tyrosine. These are our glucogenic and ketogenic. Now we have a 21st also, selenocysteine. It contains a very rare element called as selenium. It is also present in enzyme 5-deiodinase. So selenium is a trace element. MCQ. Selenium is trace element. Very small quantities. They are called as trace elements. Selenium is trace element, and it is present in 5-deiodinase. So deficiency of selenium causes hypothyroidism. So that's why selenium deficiency causes hypothyroidism because of decreased formation of T3. 22nd is pyrolysine. So now all amino acids are covered. Now miscellaneous uncoupler. So what are the uncoupler? They are your 2,4-dinitrophenol and aspirin. Physiological is thyroid. Physiological uncoupler is thyroid. Remember, physio I can put everywhere. That's my biggest advantage. Even if I don't have experience of other subject, physiology zindabad. Now lipoprotein with the highest cholesterol is LDL, and they go and carry cholesterol from liver to tissues. What they carry cholesterol liver to tissue like vessels. So that's why it is a bad cholesterol. Why? As it take the cholesterol to the tissue like vessel, cause atherosclerosis. So it causes the atherosclerosis. Whereas HDL is reverse. HDL bring the cholesterol from tissue to the liver. So that's why it prevent atherosclerosis. So it causes atherosclerosis. Now highest triglyceride is chylomicron. So chylomicrons contain highest density of what? Lipoproteins. Now nature of enzyme. Apo enzyme plus coenzyme is called as holo enzyme. Whole. Apo and co create holo. Competitive inhibitor, I told you already, I've done that in pharma. Vmax is same. So in competition you see two graphs like this. So two graphs are comparative and one is in front, one is back. So that's why their Km is increased, but velocity remain the same. So the same velocity remain the same. Okay. In this case, you get only one graph and that is going to bend. So if you see only single graph which is going downward, this is your non-competitive. Vmax decreases, Km remain the same. So Km is same. This is Km. Here increase Km. Here, and what decreases? Vmax decrease. Decrease Vmax. Here same Vmax. So this is done in pharma also. Protein folding and unfolding is done by saffron protein. Which proteins? Saffron. So saffron. Okay. Histones also play a role in yes the folding of the our chromosomes. Okay. Now come cofactors, very important. Okay. So first is cobalt is vitamin B12. That's why it is what? Cyanocobalamin. Cobalamin. Chromium is potentiate the action of insulin. That's why it is very important. Fluoride is a part of bone and teeth as fluorohydroxyapatite. So I'll write it here. It is fluorohydroxyapatite. And too much cause fluorosis, too much cause fluorosis. Okay. Then iodine is a part of obviously thyroid hormone synthesis. We've discussed multiple times. Molybdenum is for xanthine oxidase, which is the main enzyme for what? Our what? In gout. So that's why what do you do? We inhibit by what enzyme? By allopurinol in gout. So that's why you will give it to reduce the enzyme xanthine oxidase allopurinol in gout. Chronic gout. Okay. Acute is NSAIDs. Selenium, I told you, deiodinase and glutathione peroxidase. Okay. Zinc is Cal. All anhydrase is containing and dihydro. So all hydros are zinc. Remember the mnemonic? Hydros is zinc. So which hydro? Carbonic anhydrase, which is for again acid secretion buffer. Alcohol deiodinase, alkaline phosphatase, which is in bone, and lactic dehydrogenase. Lactate D, they all are zinc is the cofactor here. Manganese is carboxylase, arginase, kinase, and inverse cake. So mangao cake, mangwao. So mangwao cake. Mnemonic is mangwao cake, mangwao cake. Okay. Then vitamins. You all know BC is water soluble. BC is water soluble. Rest are lipid soluble. Let's see. Vitamin A, we all know active form is retinol, which creates our retinaldehyde. Deficiency, we have the Bitot spot. So what the deficiency causes? It causes the Bitot spot, which is the chalky white deposits, and we have the I think this part I should have covered, that in children what we can use vitamin. These were the findings. Okay, so I'll show it later if I get time. Okay, next vitamin D, we know active form is D3, which is 125 dihydroxy cholecalciferol, and it causes liquid craniotabes. Is very important finding. Plus also there is what? Fasciatic rosary. Plus there is flaying, cupping. Okay, all these are finding. And widening of epiphysis, they are in rickets. And adults is osteomalacia. Vitamin E form is tocopherol, and it is basically deficiency causes increase in poor inflammatory response, cancer, cellular damage. Okay. Vitamin K, 3 form. K1, K2 are fat soluble. K3 is water soluble. It is water soluble. So it is phylloquinone, menaquinone, and menadione. Deficiency cause bleeding. And remember one action. What does vitamin K? So I'm just teaching you something. Just write down. It will help. So vitamin K basically help in what? It help in gamma carboxylation of clotting factor 2, 7, 9, 10. So 2, 7, 9, 10. And what act on this? So I'll teach you mnemonic. You will never forget. I will make space and write the mnemonic. So the mnemonic I'll write here. Remember India and Pakistan. Okay, mnemonic is this. So remember, very simple. Okay, so always there's a war. There is a war between India, Pakistan, war. Why? Because of Kashmir. So Kashmir. And what is the between? It is between Pakistan and India. So now this is the mnemonic I made. War between India, Pakistan over the what? Over the Kashmir. Okay, Kashmir. So how to remember? K. Vitamin K is blocked by warfarin. So let's make it smaller. So warfarin. Warfarin inhibit vitamin K. Now clear? And what you check? Pakistan, PT, India, INR. So now you'll never forget the mnemonic. So what do you test? PT, Pakistan, IN is India. So PT, INR are used for checking the warfarin, yes, toxicity, and it is acting through vitamin K. So remember vitamin K, PT. And if you give heparin, okay, just write down. And it can be given oral. So remember, Pakistan, India, fight is there. So what you do? Ki oral, okay, oral fight is going. Okay, तो क्या वो गाली दे रहे हैं मुंह से? इंडिया वाले पाकिस्तान को गाली देते हैं वो, है ना? ऐसे, ठीक है? Heparin inhibit thromboxane, yeah, right? Inhibit factor 10, 11, 12. So 9, 10, 11, 12, mainly factor 10, antithrombin 3. So that's why it is causing, yes, APTT. So that is which pathway? That is your intrinsic pathway. And warfarin, we are using extrinsic. They are fighting enemies, extrinsic pathway. Okay, so this is extrinsic pathway. 7 is extrinsic pathway. So this is yes, very important. Yeah, pakka question aayega Abdul, not 1 2. Yes, it will be giving lots of questions. Okay, fine. So India Pakistan war, warfarin, vitamin K, Pakistan, PT INR. So what do you check? PT INR. So what we use? PT INR is used for warfarin toxicity. Okay, and for heparin we use APTT. Vitamin B1 is thiamine. Okay, and very important, it is deficit in alcoholics, very common because they don't eat food properly. And also there's a case polished rice, very important. There are two very commonly asked questions, and it causes Wernicke-Korsakoff syndrome. Korsakoff is basically false memories, and Wernicke's is basically Goa. Now in Goa, how you go? Taxi. So you call a taxi. Then you are very confused कि where to go to see Indians and maybe Russians. So you're very confused which beach to go, and your eyes are going here and there searching for, you know, very beautiful beach places for photo. Ophthalmoplegia, ophthalmoplegia. So that's why vitamin B1, thiamine, we have the Wernicke's and Korsakoff. False memory, that is called as confabulation. Treatment is we give IV B1 in alcoholics. Are you clear? But earliest feature is tremor. Alcoholic earliest feature is tremors. Okay. Then B2 is riboflavin deficiency cause glossitis, neural dysfunction, dermatitis. B3 was asked in this exam, niacin. It is pellagra, which is DDD, 3D, dementia, diarrhea, and dermatitis. It is 3 Ds. Okay. B5 is panto. Name itself 5, panto, 5, 5. Panto, Pach. Pantothenic acid. It causes burning feet disease. Okay. B6 is pyridoxine and deficiency again cause anemia. Okay, it causes anemia. Okay. And B7 is biotin, hair loss. B9 is folic acid, which is megaloblastic anemia and also neural tube defect. But remember, in case of folic acid deficiency, there is neural involvement is not there. So there only increase RBC size more than 100 micrometer. So size is 100 micrometer cube, and there is negative negative effect, no effect on the neural. So no neural involved, no neural features, sign symptoms. So where do you see neural? It is B12. So B12 there is megaloblastic with, yes, also there is paresthesia, tingling. So there are, yes, neural sign and symptoms. Okay, so there is neural sign symptom like paresthesia, weakness, tingling. So if you get RBC more than 100 micrometer, it is megaloblastic anemia. If there is neural features, then we will suspect what? We will suspect megaloblastic anemia, which is B12 deficiency, cobalamin. But if there is what? If there is what? No neural, suspect the folic acid, yes. Also earlier we used to do what test? We used to do the test for diagnosis like Schiller's test, Schilling test, not done nowadays. Okay, clear? So with this we'll finish or wrap up our biochemistry. Also I will save this file and I will upload it, already uploaded in the group. Okay, so last I will take PSM in just 2 minutes. Okay, I'll just get some water and come. Next 20-30 minutes I'll do PSM rapid review. Okay, so PSM will start in another 2-3 minutes. Okay, just give me 3 minutes. Okay, clear? So I've done in brief, you know, time is less, I cannot go in detail. Whatever I am doing will surely give you good number of questions in the exam. Our target is what? Just get what? At least 100 correct from this. If we can get 100 correct from this chanting material, 20-30 you can get by your own, you know, knowledge and other subject, you will surely get 130 to 140 marks. If you get 130 to 140, let's remove, this will be 65 to 70%, and you know that will make you in top 5000 rank. Clear? So 70% can, even if the paper stuff, get you in top 1000 also. So that is the idea. So I just come in 2 minutes with water. I'm back. Sorry, just having some. Yes, just replying. Please join in. Last session, last hours, last day before the class. Wow, people are still watching. Thank you very much to all of you. Yeah, the PDF is already there in the group. I'm just giving my number. Message me, I will send. 9899529468 is my number. Okay. Thank you. Thank you. Paras is also here. He's still awake. See, I take class in the day. I'm actually in Kerala, Calicut. So morning time I take my classes. And after my class is over, I come for your classes and I take your chanting sessions in the night. So it's very difficult, okay, to do both, but there's no other option. Okay, exam is there. 5th, I'll be there on the exam center to meet you people and give you best of luck. Okay. So yes, it is integrated learning. You can search, okay, integrated learning. You can see my photo. So if you see my photo, that is authentic group. In a circle, you'll see Dr. Ashish. So that is my group, and it is having all the great, questions plus chanting PDF. Okay. So the file I already showed you. Okay. It is what me and Paras use for chanting. So you can see the same materials we are using for all our sessions. Okay. So let's continue. We are doing the last session of the day, and that is our what session? That is our PSM session. Okay. So this is PSM chanting. Okay. So I'll be doing not from this. So it was done by me. Okay. So I will directly start, not here because it will take lots of time to finish, but I'll just give a basic idea. So basics is rate, ratio, proportion. Proportion is relationship and it's in a percentage. So if there's a relationship, percentage is called as proportion, and the x in the part of y, that is what is the ratio, x by y now. So x is a part of what? It's a part of the y. Like example, case fatality ratio. Case fatality ratio. Here the number of people dying because of disease. So that's why it is part of the, yes, people with the disease, the number of death. So that's why it is a, yes, it is a proportion, and it is out of 100. It's out of 100. Okay. Is the volume less? Let me check the volume. Like example, no, I think it's okay. Then come our no relationship. If there's no relation, it's called as ratio. Ratio is no relation. No relation, ratio. Ratio, no relation. Okay. So therefore, like sex ratio is number of females per 1,000 male. At birth in India, it is 949. But in the adult, okay, it is 102. So in India, females are now more than males in India. So in India, females are more than at birth it is rural 949, urban 929. Okay. Best is in Kerala. Okay. Fine. Now rate is when x is part of y, and mostly it is, so I'll use a white pen because it's great. So it is mostly 100. Mostly 100. Mostly 1,000. So whenever you take, like example, first remember MMR is a ratio. MMR is a ratio, but if you take incidence, incidence is a rate, and prevalence is a proportion. Prevalence is a proportion. Are you clear? So prevalence is a proportion. Okay, it is proportion. Why? It is in percentage. So prevalence, PPP. Okay, prevalence is proportion. Now comes the question, what is MMR? It is the number of maternal death divided by live birth into 1 lakh. So that's why they both are different. There's no relationship. So it's a ratio. But in let's say infant mortality rate, it is the number of live birth and the death. So that's why IMR will be a type of what? It's a proportion, or it's a rate. It's a rate. So IMR is a rate. MCQ. So IMR is a rate. Next question. What is the level of prevention? So remember a very simple thing. Risk disease, disability, disease, risk, disease, disability. So if there is risk but no disease, primary prevention is there. So what is primary prevention? Risk is there but disease is not yet there. Primary, and it's a true prevention. If disease has started, then we do secondary, that is early diagnosis and treatment. So all the investigation and treatment come in secondary. Now if disease is advanced and now you are looking for disability limitation and rehabilitation or prevention of death, that will be tertiary, like any kind of clutches, glasses, wheelchair, artificial limb, physiotherapy. After surgery, any care will be tertiary. So that's why, very simple, if risk is there, disease not there, primary prevention. Disease there, already there, then secondary prevention. Disease is advanced and now you want to decrease prevent the disability and yes, death, that is your tertiary. And if you remove the risk itself, it is called as primordial. Like no smoking will be primordial. If you don't smoke, if you smoke and I ask you to stop, that will be primary because risk is there, cigarette is there. If you start coughing blood or something and you get a test, that will be yes, our secondary. And if lung removal or lung transplant something, that will be tertiary. Or then someone is let's say failing an exam, so that is why failing is there, so already failed. Okay, if he doesn't give the exam, that will be yes, primordial prevention. Okay, now remember what is there in primary and in primordial, basically traditional lifestyle, healthy living is all there in primordial. Are you clear? Then primary is basically what? In primary, remember there is specific protection and health promotion. Okay, health promotion is not any specific one, like if I wear gloves or I take vaccine, it's specific protection. Whereas not eating too much salt, doing regular exercise, walking, that will be health promotion. Okay, then vaccines or chemoprophylaxis, they would be what prevention? Primary prevention. Now if you take a antibiotic before the infection, it will be primary. After infection will be secondary. Okay, vaccines are obviously before the disease, so they are primary, but sometimes vaccines are used in disease, like bladder cancer, we can use the BCG vaccine, then it becomes secondary. So all treatment investigations come mainly in the secondary category. All the things before that, like example mosquito net, so it will be a protection. Why? Because risk of malaria is there by the mosquito, so there will be a yes, primary prevention. Okay, OCP, they are for primary, but if you use in disease, you are using OCP, it becomes a secondary prevention. Okay, so I hope it's clear. So now we'll just leave it. Okay, now remember first DIDH. What is D? Disease. Disease is the pathology. Okay, then impairment is peer. What peer? Anatomy and physiology. Anything which affect the anatomy and physiology, that is structure and function, is called as impairment. Like loss of limb or loss of what? Eye, etc. is called as what? Impairment. Disability is cannot do routine work. Not able to do routine work is called as what? Disability. Like can't have sex, can't walk, that is called as what? Disability. Okay, and what is the social role that he will lose? Social, what is the term for social? Handicap. So you cannot take the hand, handicap. So handicap is social role, like cannot get a job or you lose your position or divorce, that is your case. So example, diabetes is the disease. A person has amputation, diabetic fit, that is your impairment, loss of foot. Then can't walk, can't do sex, that is your disability. And divorce or loss of job will be handicap. So handicap is social. Handicap is social. Now what is daily? Daily is disability adjusted life in years. It is basically years lost to a disease, and it's a negative indicator. Hale is superior and positive because it tells you health adjusted life expectancy. Like in India, let's say life expectancy is 72 years. Out of that, how many are lost by a normal person due to diseases he or she will face in the lifespan? Let's say 5 years, 6 years, 10 years. So you subtract that, whatever is left is called as a Hale. So Hale give you healthy life years. Okay, it is superior, and it also give disease burden. What? Daily give the disease burden of the population. Okay, next question. All Hale the loads. Remember, all Hale the load, it is superior. Now incubation period is what? It is the time taken from the entry of pathogen till the sign symptom of disease. Most common incubation, especially viral, is 2 weeks. And bacterial is few days. MCQ, bacterial few days, viral is mostly 2 weeks. That's why in COVID also 2 week is there. Clear? Yellow fever again 14 day. Okay. Measles is your, yes, what, 10 day. Measles is 10 day and vaccine is 9 months. So when you give the vaccine, 9 months you give the vaccine in this case. Okay. Now next question. Quarantine is done for contacts. Kaka. Quarantine contact. Isolation. Isolation is cases. So if case you isolate, if contact with the cases, we'll do quarantine. Duration is same. 14 day is for COVID because that is the incubation period. Okay. Serial interval is time taken from first case to the second case. Okay. Generation time is time for maximum infectivity. It's called as a generation time. Okay. It is a generation time and it is very close to incubation period. Bacteria, I told you 3-4 days. Bacteria, food poisoning can be 2-3 hours also. That is bacteria is having preformed toxins. Okay. Now, primary case is the first patient. Secondary is infection from the primary. Index case is the first case which come to the notice of the healthcare system. Index is the case. So index is first case which come to the notice. Okay. Carrier are don't express the features but they can spread. So they harbor the pathogen and can spread. Chronic is when more than 6 months is called as chronic. Iceberg is only tip is visible, that is the detected cases. And what is hidden? What is hidden is invisible, that is subclinical or undetected cases, latent, carrier, missed cases. And we use screening for that. So screening is done for the, yes, subclinical hidden cases. Clinical are already there in observation and treatment. Now, if there is no carrier, there will be no iceberg. That is asked. So remember, mnemonic is vaccines. MMR vaccine and rabies and DPT vaccine. So that is having no carrier. Like example, measles, mumps, rubella. Measles, mumps, rubella. Then vaccine for rabies and PT. That is pertussis, tetanus. They are having what? They are having, yes, our MMR plus vaccine for rabies and PT. Okay. Screening. Now there are two things. One is disease is present. This is my notes. Okay. So disease is present or not. If disease is present, now first test positive, test negative. What is the symbol we use? If test is positive, it is positive. Test negative is negative. Okay. Now if the test is positive and disease is present, it is called as true positive. It is called as a true. And true positive is sensitive. So remember, positive people are very sensitive people. And if disease is not present and the test is also negative, it's called as true negative. It is specificity. So specificity is true negative, and true positive is for sensitivity. Okay. Now one example, if I say to someone that a guy, okay, let's say there's a boy or a male. Okay, so I'll just change. Let's say you say Dr. Ashish, or let's say the notes of Paras, urine pregnancy test come positive. So it will be what? A false positive. Why? Because Dr. Ashish cannot be pregnant. So that's why it is what? It's a test which is false positive test. Are you clear? Now, what is the formula? Remember, formula for sensitivity is very simple. TP, TP, TP. How the mnemonic? TP by TP plus opposite of TP. So what is the formula? It is TP by TP plus opposite. What is opposite of TP? T opposite F, P opposite N. So that's why TP by TP plus Fn is sensitivity. It is sensitivity. Okay. Next question. Specificity will be Tn by Tn divided by opposite of Tn. What is opposite of Tn? It is Fp. So it is Tn by Tn plus Fp is the formula. It is the Fp. Okay. Happy birthday, Soumya. Okay. I really wish a very, 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 great, achievement in the exam. And I wish you get a very, very good seat and score in the exam. Okay. Thank you very much for watching at this very odd time. Okay. I hope you were studying whole day. I was teaching whole day. Now I am taking a session. Okay. So are you clear? Now, PPV is positive predictive values, all P. TP by TP by FP. So remember, in PPV, all P. In PPV, all P's are there. So if all P's are there, it is our PPPPP. Okay, 1 second. I put the charger. So it's PPPPP. Done? Now, screening test should have a very high sensitivity Diagnostics should be very, very specific. Okay, very, very specific. Now, demographic, remember, it is crude birth rate, that is number of birth by mid-year population. 1st July is mid-year population. India is around 19.1, and crude death rate is number of death per mid-year population. India is around 6.1. Now, total growth rate will be CBR minus CDR. That will be 13 or 1.3. So India is around 1.3. That is population increase at the rate of every year 1.3% is the increase. So let's say it was 1 crore, it will increase by how much? 1.3%. That is 1.3 lakh. And if India is in billions, it will be in crores. Next question. If CDR is more than CBR, it is a negative growth rate. Population is in decline. Example is Japan. Okay, Russia also. Now there are 5 stages. So graph is like this. First is a high stationary phase, where high birth rate, high death rate, lots of babies are born, lots of people die. That is why population is low. Population is low. Second is early expanding, where death rate decrease because of antibiotic vaccines, and growth rate is very high, like Africa, Afghanistan, not Afghanistan, but it should be rather Pakistan, or with these all this country. Okay, so these countries have very high growth rate. Okay, then late expanding, here the death rate also start to fall. It is India till 2020. Now India has reached actually the 4 is low stationary, where birth rate and death rate are almost similar. This is in China, Europe, and decline is when CDR more than CBR. That is the case. Okay, now TFR. What is TFR? Total fertility rate. It's the number of children born to a female in her entire reproductive age of 15 to 49 years. Okay, half of that, that is number of girl child, is called a GRR. So GRR is the TFR, but only girl child. So number of girl child, so it will be roughly half of TFR. So who's half of TFR? GRR. And if you remove the mortality rate, it become NRR. So if you remove the mortality, it become NRR. Are you clear now? So that's why first question, what is the replacement level for a stable population? So the replacement level is TFR 2.1, GRR half, that is 1.05, or NRR of 1. MCQ. India has reached TFR 2.1. India has reached TFR 2.1. Our population is now going to be stable. Okay. And what should be the couple protection rate? That should be 60% for reaching a TFR of 2.1. Okay. Now indicator HDI. HDI is for high-fi rich country. PQLI, that is physical quality of life, is for poor country like India. Okay, it is 0 to 100. It is, and 0 to 1. So mnemonic is ille. Ille is income. So rich country look at income, literacy, since years of education, and life expectancy at birth. So ille. Whereas PQLI, poor country, they look at IMR. So remember, IMR, literacy, and life expectancy at 1 year give you what? It will give you what? It will give you what? PQLI. PQLI. Okay. BPL is poverty, and I will not do this. Kuppuswamy scale is for socio-economical classification. It's on the basis of multiple criteria: housing, education, income. Now we do biostats, very, very important. Then epidemiology, and I'm sorry I'm going at very fast rate, but this PDF is 113 pages. It will not finish in 1 hour also if I go at slow rate. So that's why I'm assuming you know PSM. I'll go. So biostat is basically we collect the data from studies, survey, and then we apply the tools and do. So data could be qualitative or quantitative. Remember, qualitative is discrete, yes, no, more or less. It cannot be measured in, yes, normal data set like milligram, kilogram, centimeter. Whereas continuous data, 1, 2, 3, 4, 5, 6, or 10, 11, 12, 30, 80, 90, this is called as quantitative, like age number, hemoglobin. So it can be measured in standard unit like kilogram, meter, centimeter, second. Okay, and that's why we take average of all these data. So that's why we take the average in quantitative. Okay, qualitative, there is what? Difficult to measure. That's why it has discrete values. So we measure what? Percentage or frequency. So where we take percentage of frequency, it is your qualitative. Like example, what is your mood? So say good or bad. You cannot say 23.8. So that's why you cannot measure the mood. So mood is qualitative. Okay, like gender. Gender, you will just say male or female, or maybe transgender. So here we show the percentage of the male or female. So you cannot measure 50 like 30 point, like this is what percentage. Okay, now next question. Remember age, if I say young or old, it is quality. If I say 30 years, 40 years, it become quantity. Then I have anemia. If you measure my hemoglobin, it is quantity. If you say anemic, non-anemic, mild, moderate, severe, it become quality. So any data can become quality or quantity also. Are you clear now? So your rank is what? Rank. It is quantitative. Your rank is high rank, low rank is qualify, not qualifies quality. So it is qualitative. Okay. Now types. In quality, there are two kinds. It could be categorical data. Like what? It could be ordinal. Order is there. Mild, moderate, severe, or TNM. Stage 1, stage 2, stage 3. That is low to high. Order is there. And nominal is just name. This different name. All are equal. No relationship, no order, just like gender. Male, female, transgender. All gender are genuine and they are different biological group. Religion, like Hindu, Muslim, Sikh, they all are discrete. There's no order. You can't say Hindu superior to Muslim, vice versa. So that is why ABO blood group, all blood group are equally valid blood groups. So that's why no order, nominal. If order grading, this is called as ordinal data. So blood group will be what? It will be what data? It's a categorical data and it will be nominal in nature. Okay. If two or more values possible, it's called as dichomatous. If only multiple, it's called as polychomatous. Like example, male, female, past, female, tall, short, it will be dichomatous. If more than two, it will be polychomatous. Okay. Now comes a question, how do you measure the central point of any data? That is called as the central theorem. And we have three main things: mean, median, mode. Mean is the average value. You take sum of all, divide by the number of the data, that give you mean. Mean is for quantitative, whereas median and mode for both. Now remember mode, Modi ji. Modi is Modi ji. What is the most famous name in our country? Modi ji. Anything good? Modi ji. So Modi ji is most common, MC. Most common value, MC. Most common is your mode. So what are the most common name in this country? Mode. So that's for nominal data. So what are the most common name? Modi ji. Modi ji. So for nominal data, what do we use? We use the mode, Modi ji. Median is middle value, like my finger. So two finger here, two. So this is my middle finger. This is median. I'm not showing you finger. I'm just telling you. So this is 2. This is 2. So middle value is called as median. And remember mnemonic Om. So median, Indian say Om. Om is outlier. So outlier and ordinal, we use what? Om, double O. So outlier and ordinal data, we use median. So in India, क्या बोलना पड़ेगा? Om बोलना पड़ेगा. Outlier, extreme values, then we don't take mean. Mean will be affected by what happens? So it is affected. So it will be affected by outlier. So that's why what you will do, you will take the median. Okay. Now, next question. Mean formula you already know some. Median. In median, what we take? We take what? The middle value. We arrange in the order and the middle value is taken, formula is n plus 1 by 2. Okay. If it's a even, we take average of 2 middle value. That is called as the median. Now, if there is a normal distribution, all three are same. All three. Outlier will cause change in the median. Let's say if you add an outlier like 33, it will make the mean increase. So mean will change. But what will not change? The median will not change. I leave this example. Normal distribution is when there is what? Bell-shaped curve, and it is called as Gaussian distribution. Gaussian, okay? And it is like this, okay? And here mean, mode, all three are same. So what are all three same? All three same in a normal distribution. So what is same? Mean is equal to mode. So all three are same. Mean, median, mode. Mean, median, mode. Are all three equal? That is normal distribution. Now, next question. In normal distribution, 50% of population will be above the mean, 50 will be below the mean value. But if you take first standard deviation, SD, what is SD? It is actually an average of this, deviation of each value from the mean. Let's say I have 10 people, I take their age, average, let's say 30 years. So if I am 40 years, I am plus 10. If someone 20 is minus 10. So when you take the average, then you will square and under root, that become your standard deviation. So standard deviation is what? It is nothing but average, standardized, deviation of each value from the mean. So SD. So one SD will cover 68% population. So how much population is covered by mean plus one SD? 68. If you take two SD, the range become bigger, 95%. And 95% means what? You are very likely to be a part of normal. If you're outside 95% range, that is 5%, then you are an outlier and most likely you are a abnormal finding. That is why in medicine 95% confidence interval is normal, outside 95 is abnormal. So that is why any value which is outside the 2S2 is taken as abnormal. Like wasting, shunting, what do you take? It is 2SD. So what the rule is? If it is 95%, that is within 2 standard deviation, within 2, it is normal. If it is outside 2SD, it is abnormal. So what is the 2SD means? Normal. Outside 2SD is abnormal. So if your weight of the baby or the height of the baby is within 2 standard deviation of the normal, it is fine, normal. It's a part of normal population. Like my height is, let's say 5'2", 5'3". I am short, but I'm not a dwarf. But if it is outside 2 standard deviation of the height curve, then I will be a dwarf. Okay, am I clear now? So I'll have short stature. Done. Okay. And 3SD will be acute mal. Yes, severe. It should be severe. It will be severe. So 3 is a part of severe malnutrition or severe wasting. And severe. This I discuss in pediatrics. Severe wasting. What? More than 3 SD. Okay. So if value is within 2 SD, normal, more than 2 SD is pathological. Okay. So 19%. Now this is already written, so I'll not discuss. So severe wasting, severe is 3 SD. Now that is why even, what is the term? Epidemics. When do you say epidemic? When the cases are more than 2. So that is why even epidemics. What is epidemic? Either new cases, new disease, or cases more than 2 standard deviation. This is the definition of epidemic. Okay, cases more than 2 standard deviation. Now next question, if you add outlier, the graph will shift to one side. This is called as Q. So this is called as Q. So shifting of the graph is called as Qness. It could either be a positive skew or it could be a negative skew. Okay, and that is based on the tails. So the criteria, tail is the criteria for skewness. It could be positive skew or it could be a negative skew. Are you clear now? Positive or negative. Okay. Now null hypothesis say two group which you are comparing, they are same. If they are same, that is, I say no difference between North Indian and South Indian in terms of IQ and rank. That is my null hypothesis. If it actually there is no difference, that is these are comparable, then my null hypothesis is true and this is fine. But there are two type of error. Like what error? Alpha error and the beta error. In alpha error, null hypothesis is true, but it is rejected. It's a true thing, but not accepted. Like I say they are same, or you say no, they are not same. It is called as type 1 alpha error. Beta is null hypothesis is false, but you are accepting it. That is called as type 2. So what is true but not accepted? Type 1. False but accepted. Type 2. Now how do you compare the two groups? Basically we take the p value. P means probability value. If it is 5%, that is not in 95% confidence limit, then we take it as a significant deviation from the normal. So that is the case. Now if p value between two groups you are comparing is less than 0.05, that is 0.05, they are statistically different from each other. That means the difference is not by chance, it is actual difference between the group. If more than 0.05, it's just a chance. It is just a chance. So that's why if more than 0.05, both the groups are same, null hypothesis is true. So that's why, let's say I say COVID vaccines, Covishield and Covaxin. I say one give 90% protection, other give 95. I compare. If p value come 0.02, that is less than 0.05, that means one is better than the other. But if it come 0.08, 0.09 or 0.34, that is more than 0.05, That means the observation of 95, 99 is just a observation which is by chance. Statistically, they don't have any difference. So remember, so what actual proof difference is there or not? It is our p-value. If p-value is more than 0.05, no difference. Less than 0.05, there is a statistically significant difference between the two groups. Okay. Now, if the values, okay. Now, question, how do you obtain the p-value? We get basically by test of significance. There are two kind of test of significance, parametric and non-parametric. Parametric are basically when there is a normal distribution, non-parametric if there is a absent normal distribution. Okay, so distribution is the concept. Now, what is the type of the test? First, quality of which country is not very sure. Chinese. So Chinese product can be Puma also, Pumu also, Pumu also. So Chinese quality is never sure. So that's why for qualitative data, we will prefer chi-square. It's not chi-square, but I give a mnemonic chi-square. So mnemonic is chi-square Chinese. So chi-square Chinese. So what is the concept? We will see. So concept is chi-square. So concept is chi-square is used for Chinese quality. So for qualitative, we will use chi-square test. In chi-square, we make a 2x2 table and we compare, let's say, smoking, non-smoking, cancer and no cancer. And we compare the frequency of proportions. And if the p-value is more than 0.05, no difference. That is same. And if less, it is difference. It is different. So if less than 0.05, it is different. More than this, it is not different. Are you clear? Now, if it is quantitative data, mean is compared. What is compared? Mean, not percentage. And example, marks, height, weight. Marks who's very, very worried should. So that's why quantitative we use student t-test. What we use? Student t-test. Now remember, if you are comparing two group, we use student t-test. Okay, student t-test. Okay. Now, if there is a same group, okay, if there is a same group but different time, drug, then we use paired t-test. Like Delhi batch 1, I compare physio test versus patho test, or I compare their June marks with July marks. That is your paired. Same group, different time. That is ग्रुप वही है, जैसे पाकिस्तान टीम इज पाकिस्तान टीम, बट एकदम से हालात बदल दिया, वक्त बदल दिया, जज्बात बदल दिया. सो एवरीथिंग चेंज बट ग्रुप रिमेन द सेम. सो इफ द ग्रुप रिमेन द सेम, ओनली व्हाट चेंजेस? टाइम चेंजेस or the drug changes. It is paired. If two different group, like I compare let's say my batch MBBS, their increase in salary or BP compared to last year. So we are same group, it is paired t-test. If two different group, unpaired t-test would be applied, unpaired. Now if more than two, we cannot use student t-test. If multiple people, how will they take a trip in a Innova? So multiple group, more than two, Innova, ANOVA. What is ANOVA? Analysis of variance. It will tell you whether these multiple groups are comparable or not. So apply the ANOVA, check the p-value. If again same, it is significant, groups are different, then we can apply the t-test. So after ANOVA, we will again apply the t-test between the groups. So I want to compare students of Delhi, Hyderabad, Kerala, online, Mumbai, etc. I will do what test? ANOVA. After ANOVA, what I can do? T-test between the groups. So that is the concept here. Okay. So summary, chi-square is qualitative data. Paired, unpaired, paired t-test is same group. This is two different group. ANOVA is multiple group. And these are quantitative. Okay. Thank you very much to all the students who are still watching me do all these things. I'm really proud of you. Just 2 days before the exam, you are with me and studying with me. It's great. Okay. So question I gave you, if you compare average BP of children from hypertensive and non-hypertensive parents, what test will be? If you're checking BP, we take the mean BP, qualitative or quantitative. quantitative. So it is quantitative and two different groups. So unpaired t-test will be. So what is that? Unpaired t-test. Are you clear? If you check the percentage of hypertension in parents of two group, we are checking percentage, then we'll apply chi-square. Then we'll apply the chi-square. It will be 2 by 2 table. 80% of hypertensive parents have hypertension kids. I remind. So that's why we will apply chi-square test. Okay. Now, if BP we compare between doctor and engineers, what we apply? Unpaired t-test. BP of doctor, engineer, lawyers will apply ANOVA. Easy now? Okay. Now, graphical representation of data. So remember, quality cocktails are available only in the bar. And in bar, we should always maintain safe distance gap. And how do you go to the bar? Using Google Maps. Okay. And we see photos there in the bar. Very good photos. Remember, people drinking, enjoying. And we eat a pie. What we eat? Apple pie. So remember, bar, pie, map, pictogram, all are qualitative. So they all are qualitative. So which are qualitative? Bar chart, pie chart, map, pictogram. Okay. Now let's say a data is male, female. So obviously the data is not continuous. There must be a gap. So a gap between the two group of data like male, female or Hindu, Muslim, Sikh, it is called as your what? Bar chart. So this is a bar chart. And in bar gap is there. MCQ. Now if there is component like how many, let's say I make a data, how many doctors are male, female, 60% male, 40% female. Then I check how many doctors are MD and non-MD. So I say 30% male doctors are MD, 70% MBBS. In female, 10% MD, 90% just MBBS. So that is called as what? Component bar chart. Okay, component. Or you can make three. This could be multiple bar chart. So this would be multiple bar chart. This is pie chart. This is pie chart. It is in circular form. Rest all are mainly quantitative. Rest all are mostly quantitative in nature. Okay. Now histogram, scatter, line, frequency, polygon, and box and whisker, which has a mustache, that's called as whisker. So if you get this kind of boxes, this is your box and whisker. It is again your, but all are quantitative. Mustache. Okay. Histogram, there is no gap. No gap. So data is like you are comparing the percentage like 0 to 50. So data is continuous. It's a continuous data. So if you make a line will give you frequency curve or the line. Are you clear? Ogives. Ogives is when you take a cumulative line curve. It's called as ogives. Okay, ogives. Scatter is basically for correlation between two variables x and y, and we use Pearson correlation. It's Pearson. Spelling is correct. Pearson. So it's Pearson correlation coefficient. Pearson. P-E-A-R-S. Pearson correlation coefficient. If it is 0, 0 means no correlation, +1 or anything which is yes, positive, that is 0.5, 0.2 is positive. Higher the value, more the correlation. -1 is negative correlation. Like example, marks and the study. More you study, more the marks. But there are some people who get more marks despite studying less. There are some people study a lot, still get low. So they are like outliers. But most people are getting more marks with more study. So it's what? Positive correlation. And slope will give you the value of the R. R is Pearson correlation coefficient. Okay. And heart disease and the hours of exercise. If you are doing regular 1 hour, 2 hour exercise, the number of heart disease patients are decreased. So that's why a regular exercise person will have less number of heart disease. That is negative correlation. IQ with state. So I measure state or distance from Delhi. So as I go up and down, the IQ is same. Some have more, some have. So average IQ remain like 90 to 140. So average IQ remains same. That is called as your, yes, zero correlation. So this is positive, this is negative, no correlation. Okay. Summary I have not give. So are you clear? Where is biostats? Okay. So I think it is missing my biostats part. Don't worry, I'll upload the other file with my bio. Maybe some error in the file. Don't worry. So I will just save this file and try to. No, okay. I'll just give a epidemiology in basic idea. So copy and write with me. So epidemiology. So first we'll discuss the two type of studies. So we're doing the analytical one. First is our observational, and then there is experimental. Experimental is do, that is trial. So here we test the hypothesis. We have two group, control and this, okay, like RCT, randomized control trial, community trial, clinical trial. So these are all trials. These are all trials. So whenever they mention trial, the diagnosis is a diagnosis. Doing diagnosis, so much medicine is filled in the brain. Even now I'm saying diagnosis, okay. So it is basically what inference we will gather. It is an experimental study. So experimental study. Then observational is all C's. C. They're all C's, like case control, cohort. Then so case control, cohort, okay. Then cross sectional. So all C's are there. So all C's are observation, okay. Now experimental are superior, and RCT is the preferred one, and the best RCT is randomized, double-blinded randomized controlled trial, RCT, okay. Now what is double blinding? Double blinding means the subject and the investigator are not aware. Both are not aware which group is getting what treatment or what group belong to which one, clinical or the study or the control. So that is why it is double blinded, okay. And randomization, really sorry, voice is gone. R is randomization. Randomization basically is to remove what? Remove confounding and bias. So how do you remove the confounding and bias? It is by randomization, okay. And subject is first blind, subject bias, investigator bias. It has which bias? Selection bias. So investigator can change the study by picking up different group. That is called as a selection bias. It's called as a selection bias. Randomization, remove confounding and bias, okay. Bias is mainly removed by blinding. Double blind subject is this. Triple blind is best, but most common is double blind. Here what happens? Even the analyst, data analyst, is not aware, is not knowing which group belong to which study group, okay. So that's why even the analyst is not aware what is the group A and B, which is study group, which is control group, okay. That is called as triple, but most common is double blind, is most common, okay. So for bias, what is the treatment? Blinding. So what is the best for bias? Blinding is the solution. Why? A blind person cannot discriminate. So that's why bias is corrected by blinding. Best is triple blind, but most common use is double blind, okay. What does investigator do? Selection bias. Subject can have recall bias, okay. Now last thing that we'll discuss here is, in the case they ask randomization, what is the best? Stratified randomization is best. Why? If you just take randomly, you might make mistake. Like example, some area Hindus are more, some Muslims are more, and I'm doing a study on, let's say, veg, non-veg or B12 deficiency. So vegetarian have more B12 deficiency. So if I'm taking a data and I say, oh, Gujarat have more deficiency, but I should take what? Hindu and Muslim group, like 100 Hindu from Gujarat, 100 Muslim from Gujarat, compare their vitamin whatever B12 level with, let's say, UP, 100 Hindu, 100. Now I am making a group and compare. That's called stratified randomization. And best randomization, best is stratified, randomization. We have what to do? First we make groups, stratas, and then pick from that. So that is stratified random sampling. Are you clear? Now we'll discuss the C ones. In C, I will give a very simple summary so that you never ever forget. Start like me. 2023. I see number of patients of, let's say, disease. Okay, so I get their prevalence. This is cross-sectional study. So see, I'm teaching despite my throat, which is since 9 o'clock working. So I think you can also appreciate and attend the last point. It's the last point. So number of patient of disease, we check the prevalence. This is cross-sectional study. Are you clear? Now I have in 2023, I have a group, that is a cohort of smokers, and I study them in 2030 for cancer. Out of this, how many have cancer? Clear? How many have cancer? So this is your cohort study. This is the cohort study. How to remember? Cohort is basically, it's a prospective, future looking study. Prospective, and it is going from cause to the effect. Cause to effect. Are you clear? So it's a forward looking prospective study. And what it will give me? It will give me new cases, incidence, new cases. Are you clear? So what will give me incidence? New cases. What will give me prevalence? Total number of cases, that is cross-sectional in 2023. Okay. Are you clear? Now, just next 5 minutes, I will finish up. Okay, 5 minutes. Okay. Now, question is incidence is what cases? New cases. Okay. Now, relatives always are asking. What they are asking? Hoga, nahi hoga? You will pass or not? Hoga, nahi hoga? So that's why relative risk. And also attributable risk. So these are what? Your cohort study factors. So they are which factors? Cohort study factors. Are you clear? Fine. And if I take patients, I take patient cases and I ask them their history 2015. I take cases when started smoking, I take history. Take history. When started smoking. So already I know I am going backward. So this is called as case control study, because I am going backward from the present to the past. So that is case control. And in case control, I'm going from the effect to the cause. So I'm going in backward direction. I already have the disease. I'm just going. And that's why it gives me odds ratio. Odd, done, done. Already disease, done, done. So odds ratio. So where do you get the odds ratio? In this case. Now, what is cheap and easy? Yes, already disease. I take the history 5 minutes. So it's cheap and less time consuming. It is costly. It is costly and long time. Then if it's a very rare disease, what is the problem? 1 in million. So I need a cohort, a group of 1 million to get the disease. So it will be very difficult to perform. So that's why it is not for rare disease. For rare disease, what I will do? I will just find the patient with the disease, take a history. So for rare diseases, it is for common ones. It is for common diseases. What is superior? Cohort is, just give me 1 minute. Yeah, I'm back. Sorry. Yeah, it is going backward. It's going from disease to the cause. So effect to cause. So it's backward, retrospective, or back. But it is cheap. Why? You already have the patient. Just take the history 5 minutes. But patient can lie. So recall bias. Here, observer bias, called as Hawthorne bias. So patient behavior change. That is change in behavior. I say I'm doing a study on cancer and impotence or smoking and import something. So then the patient stops smoking. So that is change in behavior on observation. Like when you put a security camera, the workers start working more seriously. Change in behavior on observation. It is called as Hawthorne bias. It is called as a Hawthorne bias. So how do you remove? Don't tell them what is study about. Just say, Acha, you're smoking, how long you smoke, daily how much, and then check for their cancer development. That is called as, yes, don't tell them, blinding. So we can do the blinding in this case. Are you clear? Lastly, so summary is, if there is, let's say, some new cases, there is, let's say, first COVID, we will do a case study. We will do a case study. Then we get 2, 3 COVID patients. Then we'll make a case series. Then we get a case. Now, as they are more, we will have what? We will have, next step is, I will do a cross-sectional study. What study? Cross-sectional. That is percentage of COVID in the population. Are you clear? Then what I do is, I do a case control. Case control. Like, I will take the COVID patients and the contacts and do a study. So I will do case control, and then I will do my cohort. I will make a group of people and study how many develop or not. So that's why what is the best study? It is cohort, but very time consuming, costly. So what is the case? First, let's say cases of dog bite are coming. So I don't give a importance. Then there are 3, 4 new kind of dog bites coming. Now it become a case series. Now I check how many patients in that locality have that dog bites. That is cross-sectional. I will get prevalence. Then what I do is, I take the patients. After this, take patient and ask history. Where were you? What you were doing? Which dog bite you? That is ask history. That is case control. And then I make a group and wait for disease and see disease developing. Start. This is cohort. So this is cohort, very easy. So that's why if 1 or 2 case come, it is case study. Multiple cases, case series. Then I check how many are there. Cross sectional, that is number of cases, percentage, that is prevalence and prevalence study. Then I do a case control study and I get odds ratio. Here I will get relative risk and incidence. So what is the best study? So best study is cohort, but even best is your RCT. So what is the order? So strength of evidence. Last thing. Strength of evidence. Today I taught from 9 a.m. to 1 a.m. That's almost 16 hours. So I started 9 a.m. my class and it's 1 a.m. and that means 16 hours. Just breaks are there, obviously lunch and dinner break. So that is the today's record, 16 hours of class. So strength of evidence, okay, and I took the class. So strength of evidence, best is your meta analysis. It is basically multiple RCT or other studies. It is superior to RCT. So what is superior? Yes. Then comes our, because I gave, see, I am not having time. Still I am trying to explain everything, not just reading it randomly. Then RCT is superior to what? Cohort. Cohort is superior to case control, where disease is already present. So you cannot study the, yes, the new disease. And then superior to cross-sectional. Cross is superior to our ecological, which is then superior to case report, case series. So are you clear? So this is your basic idea. Are you clear now? So what you get first, some cases, then you get more cases, then you can do an ecological survey, that is population. Of population. Other, we are just checking individual. Rest are individual. Rest individual is unit of study. So what are the only when where population is the unit of study? It's ecological. Others are individual, because you're taking data from individual. Then cross, case control, cohort. So this is a 100% exam question, or the strongest strength. It is your meta analysis. Okay, meta analysis. Are you clear now? So meta analysis is there. Now last thing they will ask is cohort is two type. One is retrospective, other is prospective. So retrospective has feature of both case, it is better than prospective. So what is the difference? It is same. Only thing is the study we will start in what? In present. But we take data from, like let's say I take a data of college student from 2015 and I see how many were smoking, and then in 2023 how many have. So data I am taking, study I am starting in present, but data I am taking from 15. So that's why I am looking at the group, seeing how many started smoking in 15, 16, how many cigarettes, and then today in 2023 how many are doing the, this is called as what? Retrospective cohort. So I take a group in 2015 and I check in present, this is the case, and prospective is 2023 to 2030, it will be prospective cohort. So if you take a group now, and that's why it is easier to do, it is giving the less, expensive, that is called as your retrospective cohort. So this is the final thing. I will wrap up here. I don't want to take any longer, it will be then useless. Okay, so PG program, yes, we are doing PG program with DBMCI. So Dr. Bhatia Institute, we are doing our all PG courses. There's no separate batch we are running, because we are only concerned with the classes for FMG exam. Okay, for PG, yes, you can join and take DBMCI. We are there. Okay, so thank you to everyone. Best wishes. Is the longest session and we have covered our chanting. Please don't ask me for any more chanting, because I can do. There are multiple topic I am still having, because usually we do chanting for 100 hours. That is, we do 10 hours for 10 days. But in your case, I was only getting just 30 hours. So that's why you can easily understand. I have to go double, triple speed. I have to cut the content. So in 30 hours I did for NEET PG. But I wish next time we'll get more time. We'll do more better sessions for you people. See, your main classes are there. After main class, how to remember, recall and get final touches. So we are doing like this, a post-translational modification. than by endoplasmic reticulum. So that's why we are doing post changes, and they are very, very okay. So best wishes, any doubt, any problem, I am there. Again, I have to go 9 o'clock, take class, wake up 8 o'clock. So 9899 529 468. It's my number. Also, DBMC, I will be giving you the PDF. I will upload all these PDFs in the group. Please, if you don't get, I'm really sorry, but I think whatever you are seeing and doing is more than sufficient. Okay, so thank you very much. Good night, take care, sleep on time, because exam day to wake up and reach 7:30. Okay, so but please wake up on time and sleep on time. Okay, good night. Let's, yes, say bye bye, take care, bye bye. Thank you very much. Yeah. Keep studying, because that is the main motto we want from you people. If you are studying, preparing, you will all get what you want. Okay. Remember, best is not getting best rank or best seat or best college. Best is the one who create the best from any possible subject, any possible score, any possible. Okay. So I want you people to get the best in this case. Are you clear? Yeah, I have taken the admit card, don't worry. Okay, and I'm going for the exam, don't worry at all. Okay, so that is the case. Okay, so yes, we have done and discussed. Good night, take care, bye bye, good night, good night. I'm ending the session. Good night to all. I gave you motivation. Na? The biggest motivation life is, okay, hard work beat everything. I'm telling you, I am not famous in physiology or this PG coaching because I am something, because I am the hardest working in as PG. When my other batch PGs were doing something else, I was day and night studying. I read Harrison in my MD time. I cleared all my remaining concept, go to hospital and see and get the clarity. Like in physiology, we are taught some spirometry. I will go and check the finding and match with what is taught. And I was trying to bridge clinical and non-clinical subject. So I didn't started taking classes. So I worked hard in my MD. I worked hard as a teacher. So that's why I'm telling you, hard work is the key. Don't worry about the result or the rank. Whatever rank you get, just do one thing. Just give your best to that department. Better be a what best microbiologist like Nasir sir rather than a average cardiologist. I'm telling you, I agree. But an average cardiologist will not be having good practice, good number. Better try to become. Some people focus more on getting seats, rank, documents rather than on improving your two skills. One is the treatment, management, whatever, and second is people skill. How well you are able to convince a patient to trust you and come to you again. That will not be taught by a medical college. It will be self-taught. Second is how well you treat the patient. Again, even that is not taught in any department. So both these things, once you learn how to manage patient clinically and how to, yes, manage patient in socially, it's an unbeatable combo. Social plus clinical skills. The one who had, so I don't have clinical, but I have teaching skill. So social plus teaching skill make me very good teacher. I want to do the same thing. Okay, that is social skills and clinical skill. You will be the best doctor. You will be having line of patient running after you if you want treatment only from you. So that's why I want from you. Take care. Oh, pakka Parveen bhai. So whatever question I will explain. Okay, so I'm going for the exam. Okay, and I will only solve the question which are from the chanting notes. So I will see how many were there from the chanting notes. Okay, surely I will give the answer. Okay, so very nice to see you here. Dr. Praveen is here. Okay, 1 o'clock. That's great. Okay, take care. Good night. Okay, very happy to finally end with a very positive note. That is, be hardworking, be sincere, then you will be successful. Don't look for seats, MD, MS. I'm telling you, okay. Nowadays, every field you have successful people, and they are because of their hard work. A tea seller can become prime minister, okay, and someone born in a very big political family can still remain, someone. Okay, you understand? So that is the case. Chalo. Good night. Okay. Good night to Dr. Praveen also. Okay. Keep helping students. He is very good at giving motivational, not just academic. He's obviously a very great teacher, but also he's always supporting lots of time. We refer to our students for him कि थोड़ा सर से पूछ लेना, help लेना, and is always there for all of you. So take care. Bye bye. Good night. We'll see all.